Yes, we are live now. You can go ahead. Welcome to OrthoTV.
Okay. Thank you, Neeraj and Ashok, for providing this platform. And friends, welcome to this unique webinar where we'll be discussing approaching proximal tibia. We all in we are all fortunate today. We have a wonderful expert panelist, Dr. Tanna, Dr. Gadegone, Dr. Vijay Kakatkar, and we have excellent faculty members, Dr. Jignesh Pandya, Dr. Sanjay Sarvaiya, Dr. Kashyap Ardeshana, and Dr. Pranav Shah. And these are the topics we are going to discuss. The anterior midline approach, then we'll be going to posteromedial approach, medial submeniscal arthrotomy approach, suprafibular approach, the direct posterolateral approach, the Frosch approach, and methods of elevation of articular reduction. And also we have some interesting cases for discussion today. We all in 70s and 80s started learning about various types of tibial condylar fracture just to freshen up ourselves. And the Schatzker classification were the mainstay of our classifying system. And those beyond 2000 were fortunate to have the new classification systems. And the CT scan coming in evolved a lot of fracture patterns, and the study, the methodology of fixation is continuously evolving. We are all happy when we have a very good wound healing, a good range of motion, and a good function in patient. However, in some patients, if the soft tissues are not handled properly, we also have to manage infections. And soft tissue optimization in tibial condylar fractures are really emphasized. The concept of spanning, scanning, and planning has come a big help in managing tibial condylar fracture, and we'll be discussing all beyond this. Use of edema reduction measures, etc., are really important for managing these soft tissue injuries. And when problems happen in wound healing, we have to manage the infection in certain cases of this patient. The modern day tactic involves 4 primary areas of management: the amount of articular depression we have to manage, the extent of condylar displacement we are getting, the degree of metadiaphyseal comminution we have, and the associated soft tissue injuries, whether the ACL, MCL, or the posterior cruciate ligament, and the assessment of column involvement and the apex buttressing required and the anti-glide plate required. All this has provided a column specific fixation, and that has changed the results and the outcome of the tibial condylar fracture. So friends, today we are going to see all the approaches around the proximal tibia, and may I invite our first speaker, Dr. Jignesh Pandya, to kindly share his screen and start his presentation. Since Dr. Sarvaiya has a logging in problem right now, so we'll be starting with the posteromedial approach. Dr. Jignesh bhai, can you share your screen?
Yes, sir.
Yeah. Share the way you just shared right now. Share the screen, and yeah, absolutely fine. So for a change, Dr. Jignesh bhai would be taking a posteromedial approach rather than the posterolateral. So welcome for posteromedial.
Yes, sir.
Yeah.
On the outset, I will say this is a very common approach, and most of the viewers must be doing this approach regularly, routinely in their practice. So there will not be anything great or new thing which can be seen in this approach. But I have got my few tic-tacs, and usually this is a posteromedial approach for a posteromedial condyle tibia. But you can do posterolateral condyle also from this approach. So how it can be done? You can see 85% of posterior tibial articular surface from this tibial condyle from this approach. So how can we get access? So I will put it as an extended posteromedial approach, and that will allow, it is a classical approach for posterior bicondylar tibial fractures, because so many times you will see that posteromedial condyle is there, but along with that there is a posterolateral depression or impaction is there. So we will see here 2 cases, in which one case posteromedial is a major fragment, posterolateral will be a depressed impacted fragment, and second case will be a posteromedial small undisplaced or minimally displaced fracture, but posterolateral will be a large depression of the whole condyle. And how we did it, so we will see both the cases, and I will see edited very nice video, and I'm sure that after seeing this video everybody will be able to do it in the clinic. This is a very simple approach and there is no danger. First case, this is a posterior bicondylar tibial fractures. The CT scan is there, and you can appreciate with my arrows. The red arrow is showing posteromedial condyle in coronal plane as well as in the 3D picture. The green arrow is showing that the lateral condyle outer rim is intact with posterolateral part. So lateral condyle medial half, posteromedial half of the lateral condyle is depressed and impacted, and the round circle is showing that this is the impacted lateral condyle, right? Now we will directly go to the video. Prone position, left side thigh. The transverse line is the popliteal crease, and I just curve the incision a little bit on the central side from the medial side. I'll cut skin and subcutaneous tissue gently. Don't go very deep, otherwise you will cut the gastrocnemius muscle. Bleeder comes, you just cauterize it. Second step. Now I will develop the interval between the semitendinosus and medial head of gastrocnemius proximally, and I will cut the fascia over the medial head of gastrocnemius. My finger is running and palpating the semitendinosus muscle proximally. That should be saved. In initial few times I could nick it, so we have to be very careful. We don't have to cut the semitendinosus. Now you retract, separate, run your finger under the gastrocnemius medial head and separate it from the underlying popliteus muscle. Now you can see in the floor, popliteus muscle, which is retract, and the medial head of gastrocnemius is retracted by the assistant from opposite side with two large retractors. And I am palpating the posteromedial border of tibia with my finger, because my knife is going to touch the posteromedial border. It should touch the bone when I cut the popliteus muscle origin from the posteromedial border of the tibia. You can see how my knife cut directly on the bone. So it will elevate whole the popliteus muscle from the origin, from the medial border. You can follow it. Cut with the knife only. Don't use too much of blunt dissector and periosteum elevator. Uska chunda ban jayega muscle ka. So you cut all the fibers from the dissect subperiosteally. Reach to the bone and stay on the bone is the principle in this approach to prevent the injury to the vessel. Now I will be cutting the proximal tendinous part of the popliteus muscle from the posteromedial surface of the tibia. I am cutting that tendinous portion. When you cut this tendinous portion, be careful. You cut the fibers which you see it, because medially just next to it, it is a popliteal artery. So if you cut blindly, you can nick the popliteal artery. But it is very safe. You will see the vessels are far off from the muscle actually. So the muscle is totally released. Now I will show you release muscle. Whole popliteal muscle from the origin, proximally and medial border is released. And the vessel I will show. This is the vessel on the popliteal muscle. So popliteal muscle will be protecting the vessels. Okay. Now I will be doing tenotomy of the medial head of gastrocnemius muscle, as I want to go posterolaterally also. Because if muscle is not cut, then it will not allow that much retraction. If somebody want to do only posteromedial condyle, then I think this much dissection is enough. You don't need to release the medial head of gastrocnemius and don't need to release the soleus. But here, as we want to go medial half of posterolateral condyle, we will release both. So muscle is released, only tendinous portion is cut, no muscle fibers are cut. Now we will see soleal line. This is soleal line, and I will be releasing soleus muscle from the soleal line. And I will release from distal to proximal. My knife will be reverse. Because if you go from proximal to distal and enter in the muscle, you can likely to cut posterior artery. So it is very near that soleal line. So we have to release from the subperiosteally from distal to proximal manner and cut only tendinous portion and go on palpating with your finger that you release completely. I have palpated my finger. The soleal line completely release soleus muscle, and then you will be able to go far laterally. It is released. Now we will see medial condyle, posteromedial condyle. Now the complete dissection is there. You can see whole posterior surface of the tibial condyle, and you can reduce the condyle as per the displacement. Now plating is done. The posteromedial plating is done, and now we will focus on a posterolateral condyle. both the spikes on the lateral surface of tibia, and my suction is in the joint. Now you can see the light is there. Then you can see the depressed white articular surface of the posterior condyle. That is the articular surface. That was elevated, and you elevate maximum till you don't see the articular surface. Put a filler and then put a plate. So plating was done, and this after plating, this is the muscle. You will be able to see second plate also. That second plate inside, and that's the vessel lying on the popetus muscle. So this is one exposure. This is the closure, incision and closure, and you can see post-op X-ray, and that's the follow-up after 1.5 years. So that's full healing, and both the plates are in position. Good reduction. Another case we will see now. This is the AP X-ray of the tibial condyle fracture. I thought it is a fracture lateral condyle tibia. Now it is a, you can see there is a vertical split showing the posteromedial condyle, and the slope of the lateral condyle is going posteriorly and facing posteriorly. Now we will see 3D CT. So we can see large posterolateral condyle is totally inside the joint. Lateral margin and anterolateral margin is totally intact. There is no fracture there. And posteromedial condyle is seen on end-on view. Classic. It is so again it is a posterior bicondylar tibial fracture involving both the condyles. And posterolateral condyle is a split depression fracture. You can see there is a vertical split in the cortex posterolaterally, and there is a depression of the articular surface. As it happens in anterolateral side, exactly same thing happened on the posterolateral side with fibula head intact. So this is posterior bicondylar tibia is the diagnosis, and you can see split depression fracture of posterolateral condyle. It is facing direct posteriorly. So posteromedial condyle needs posteromedial approach. It dictates the posteromedial approach, and posterolateral condyle needs posterolateral approach. But here both the things are there, so we can avoid double approach and we can do single approach, extensile posteromedial approach, which can allow fixation of both the condyles together. So again we will see the same approach. It will be a sort of a revision thing, but we will see how the posterolateral condyle seen in this approach very nicely. So again the same incision, skin subcutaneous tissue cut, just curved beyond the crease of the beyond the popliteal crease. Cut skin and subcutaneous tissue gently. Don't make very bold incision, and you will be able to develop the plane. Now this is artery is showing the hamstring muscle, semitendinosus. Now I will develop the plane between the semitendinosus and the medial half gastrocnemius. There will be fat there, so the tendon is embedded in the fat. So you palpate the tendon and then cut. Otherwise, you will cut the tendon. I have separated it. Then I will separate the medial half gastrocnemius from the popliteus muscle. Running my finger underneath the medial half gastrocnemius, and in the floor, you will see popliteus muscle. Now I will cut the popliteus muscle directly as done in the previous case. My knife will touch the bone. When I cut the muscle, my knife should touch the bone. That's the criteria. So you are safe. My knife is touching the bone and cutting the muscle. Completely. Cut muscle completely up to the bone. Go up to proximally up to tendinous portion, but don't release the tendinous portion first. First you release the muscular part, and then cut the tendon by palpating, so you don't damage the vessel. I will show you in the next slide. I am erasing the fiber with a knife only. Now I will elevate the fibers with the periosteum elevator. Okay, so I will create a space. Now I will cut the tendinous portion. I have put up the spike already underneath the popliteus, and I am cutting the tendinous portion by palpating. It will give you release feeling. I am releasing it. I have released it. See and cut, and then palpate with the finger. No tendinous fibers are left, because next to it will be a popliteal vessel. Just be careful. Not very dangerous. We are all surgeons. We can take care of the things. Then pass a spike underneath. Yeah. The spike in the lateral body of the tibia now. The remaining fibers are erased. Now you can see hematoma is coming out from the lateral condyle. So this is a posterior condyle, there is opening there. So split depression fracture, hematoma is coming out. Now this is the muscle and there is the vessel. I will show you the vessel. Vessels are very nicely protected by the muscle till the upper end of tibia. Beyond that, there is no muscle protecting. The vessels are directly there over the capsule. This is the vessel. Yeah. Usually I don't see like this, just for video purpose and showing the things I recorded it. Now this is soleal line. My tooth forceps is running on the soleal line. That are fibers of soleus muscle attaching on the soleal line. Again, I will release from the distal to proximal manner, releasing all the tendinous portion of the muscle. Don't enter in the soleus muscle mass. Just release from the tendons. So there is no bleeding. There are no bleeders in this region except a medial genicular artery and a purpuratory artery. Otherwise, you don't find any bleeder after releasing tourniquet. So if you see bleeding, then think of these two things only. Completely release all the fibers of the soleus. There are some fibers are remaining. I will release it. Now we'll do tenotomy of the medial half gastrocnemius. As I have shown that with the fibers. Now I will cut only tendinous portion, tendons, white. Don't cut any red fibers. So don't cut the muscle. At the end of the procedure, you don't have to suture it also. Just leave it. See, you can give release feeling. Yeah, or released. Palpate it. Any of the fibers are remaining tangent band, release it. So it will give you access to the posterolateral part of the condyle. Otherwise, the muscle will not allow it to go that much retraction. I palpated everything. Yeah, I can go there. Now this is posteromedial condyle, and that's the posterolateral condyle window. I am pressing the window split. This is soleal line. My forceps is running on that. That's the capsule, and that's the medial condyle of the femur. That is the medial condyle. Yeah. So you can see from medial condyle of the femur, this. Even medial HOPA fracture can be fixed from this approach. Posteromedial HOPA, posteriorly, posterior small part. Now you can see that. That's the window. And you can see arrow, picture is there. What I am handling, 3D CT picture is there. So I am opening that window. Posterior cortex, posterior cortex. Medial posterolateral plating is done first. It is always better to, when you are doing posterolateral condyle, first do posterolateral plating, complete it, then do posterolateral condyle. Because sometimes the tibia is posteriorly displaced, so you will not be able to see it properly. So first better to complete posteromedial fixation, and then you can see wide articular surface. I have elevated that split, and you can open that articular surface. Yeah. It will be just in front of your eyes. This is how it looks like. I have put the 3D picture, what we can, articular surface of the tibia, we are seeing it. And you can see the white articular depression. Total condyle is almost seen. And you can elevate from this same window. This is the articular surface which we can see. The depression. The whole condyle which is depressed can be palpated. Suction can be put in the joint, aspirate the hematoma, and then elevate and fix it. Now I will be elevating it. So I will start from proximal to distal. I will get my osteotomy exactly under the fragment with some bone, subchondral bone, good amount, and then elevate it completely like this. I will elevate till I don't see the articular surface. That will be the maximum, because lateral condyle of the femur will act as a template. So I cannot do over elevation. Just give some traction to the limb. So it will open up the joint little bit, and you can do little bit over elevation, over correction of the depression. And then what are the gap remaining? You can put one K-bar also underneath the fragment after elevation, and then put up your filler. I usually use a Kronos or a bone graft if patient cannot afford. Filler, and then close the window and put a plate. So this is the window which is closed after elevating and filling the Kronos. See, I can reduce it perfectly well. The window is completely closed. Then I will buttress the elevated fragment with 2 screws proximally and the plate. This is the plate. Second plate is fixed from the same approach. Both the plates are seen. And that's the closure time. Popliteal muscle will cover both the plates. You can take suture also. 1 or 2 sutures. It's like a pronator quadratus in the wrist. Similar. The popliteus is like a pronator quadratus in the wrist. Exactly same way you have to cover, you have to elevate, release everything. And vessels are there, you can see. And that's the post-op X-ray. Elevated, fixed. So tibial condyle fracture is like this to the surgeon. He tries to kill the surgeon. But we have to take every risk and drop every fear to come across. And I cannot teach anybody anything. I can just think. Thank you very much, sir. Thanks a lot.
Thank you very much. That was wonderful.
Yeah,
So,
it was like a 3D movie. We were going inside the posteromedial area.
Yes. We could see, and the pictures he captured were really very explanatory. And 3 points he emphasized very well: that don't vigorously retract, put the right angle and the retractors at an angle, then go from distal to proximal while cutting the soleus muscle. That was very well emphasized by him. And not to venture into the field where the vessels will come in between. So vessels are always protected by muscle. Thank you very much.
So if you protect the muscle well, it will not damage the vessel. Yeah. If you don't protect the muscle well, then the vessel will be exposed.
Jignesh bhai, may I ask one question?
Yeah,
please,
go ahead, sir.
My pleasure. Please.
Excellent disposition of the subject and video presentation. But my objection is only one.
Yes, sir.
It is very difficult to address the posterolateral fragment by posteromedial. Though you are an expert and you can do it.
Sir, हम दोनों एक बार साथ में कर लेंगे अपन मैं आपको दिखा दूंगा बराबर.
It requires much more retraction than needed, and therefore why not to have a different approach so that we can have address better way. Sometimes
Sir,
very difficult to address the an elevation of the posterolateral fragment elevation by this approach. So there is a limitations are there, but it is the best approach for the posteromedial fragment you have advised. Thank you very much.
Thank you, sir. Thank you very much, sir.
Any question to Jignesh bhai? Kakatkar sir, you wanted to ask?
Yeah. Jignesh bhai.
Good evening, sir.
Yeah, good evening. Excellent disposition of this approach. As usual, I have seen it before also.
Yes.
Well, the only thing is, do you like to keep the knee in slight flexion and plantar flexion in the ankle so as to keep the muscles and the vessels relaxed?
You can do that, but what happens, sir? Medial condyle reducing in extension. So you can, during descent, you can keep it in little bit flexion, but at the end of the, when you are doing reduction and fixation, you should do extension of the knee, because medial condyle will very well get reduced in extension and not in flexion.
Yeah,
Flexion will be difficult to reduce it.
So
sir, once you release the muscle, there is no difference in a flexion or extension. Doesn't make any difference.
Okay.
So what Dr. Kakatkar sir is pointing out is dissection in flexion and reduction in extension.
That 10-15 degree flexion can be kept, but doesn't make much difference. Sir. I have done more than 50 cases like that. Now it doesn't make any difference, I tell you, frankly speaking.
Yeah. Now we are ready with Dr. Sarvaiya sir's lecture also.
Before we move on to Dr. Sarvaiya, let me just address a little bit to what Dr. Gadegone had said.
Yeah, go ahead.
Even I had this, I had this apprehension of going to the posterolateral condyle before. I would do only posteromedial condyle probably 4 years ago. But as Jignesh bhai said, once we have done the 2 releases that he has very clearly shown, then very true, not just that it is in his hands. Even if I have been able to do it, my friends and colleagues in our WhatsApp group have been able to do it. So what he's saying is very true. Let us not think that it is something which requires a X level of expertise. It just requires the steps, proper steps to be taken, proper releases to be done.
Sir, you can see 85% of posterolateral tibia. That's all. 85% surface. That's all. 15% you cannot see. You cannot go up to fibula head. Not possible. You cannot see posterolateral rim. You cannot see lateral rim. Not possible.
Yeah. If you want to go laterally, do you curve the incision more laterally in the popliteal crease?
Sir, you can curve it, but it doesn't give much access to the lateral condyle then. You can just give a little bit relaxation to the skin.
Sir,
But right angle incision will give more skin problems than this curved incision.
And skin is never the limiting factor.
Limiting
It is a
factor, yes,
muscle.
right. Yeah.
It is a muscle.
Sir,
And
this
you
is
can always
maximum
extend it on both directions. The incision can be extended. That's
extended
already.
both the directions.
And
But
any
there won't be much
difficulty,
of the exposure, sir.
Yeah.
Other than this,
Any-
not possible.
any difficulty in putting the trajectory of screws in the lateral plate from this approach?
No,
Yes,
sir. You,
that is very
Yes,
true.
yes.
sir, sir,
yes.
I tell you.
I
tell
will
you.
be
How do
able
you
to
manage
put
that?
only one
How do you,
screw.
that is what is the difficulty.
Yes.
Yeah.
Sir, if you release the gastrocnemius properly,
Right, right.
if you release the soleus properly,
Right.
you put two broad, nice spike over on the lateral tibia and then pull to maximum, no problem. There will not be any damage to the vessel, that is for sure. Okay. Then keep
Jignesh bhai ka wada hai.
traction and then use a sleeve and do vertical drilling. There won't be any problem. You can put all the screw wherever you want to put.
Okay.
Chandak sir.
Yeah. Go ahead.
Can I finish my presentation, which is in the continuation to the medial approach? Supine
Absolutely
medial
fine.
in the medial meniscus, because it is in a continuation of this.
My audio is there? Audio? Can you
No,
hear?
Yes, Sanjay bhai, we can hear you. Only the volume
Yeah,
is.
Sanjay bhai, we can listen to you. So we just finished one presentation and now we are proceeding with Dr. Kashyap's presentation and then we'll take up your presentation.
Okay, sir. Okay.
So by the time you can relax, no problem.
Right.
So after finishing this posteromedial approach, now Kashyap, you can go ahead with your presentation.
Yes,
And
yes.
yes, you can share your screen. Absolutely fine.
Is my screen visible, sir?
Yeah, we can see your WhatsApp screen. Now we can see.
Yes, sir. So now I was to speak only on this medial submeniscal arthrotomy, but what I feel useful is because there is this supine approach is also possible in medial. There are a few slides on that. I think I will say that also. Is my screen and presentation visible, sir?
We can see, but your voice is breaking. So
Hello?
can you put off your video, your own video?
Am I audible or visible, sir?
You're
Because I
audible.
don't listen to your sound.
Yeah. So voice is breaking a bit.
Hello?
Yeah, go ahead. Kashyap, go
I
ahead.
stopped saying because I was whether it was audible and visible, sir?
No, it was audible, but the voice was breaking. Now try again. Just try one.
Yeah, okay. Is it now?
Yeah, it's better now. Better.
Audible and visible?
Yeah.
Yes,
Yeah,
perfect.
Good.
So I'll be speaking on two small topics. One is the supine position and medial bicondylar fracture, and medial submeniscal arthrotomy. When, why, and how. The all medial approach is already wonderfully described by Jignesh bhai. So there is nothing to detail about that. But there is quite often incidents where you cannot do in prone position because you have something else to address along with. Anesthetists may not allow, or there is a lateral tibial condyle which is in conjunction with medial condyle. Then this approach in a same approach can be done in a supine position. This is how our OT setup is going to be. Then you can see this. You can see my cursor.
Yes.
Yes, we can see.
Yeah. So this is how patient is positioned. We keep a small, sandbag or a bump opposite on the opposite under the opposite buttock, exactly under the buttock, not under the spine, not under the thigh, and then we can see this type of vision from the opposite side. And I'm operating from the opposite side. This is going to be my incision. I'm not going to describe detail of the approach, but this is what you see initially. And this approach, what is more easier is whenever there is an intromedial tibial condyle also, or you want to do a submeniscal arthrotomy on the medial side, then it is very much easy in the supine position. This is again is what Dr. Jignesh has shown. This is a nice view of the popliteus. This is the gastrocnemius medial head visible, and this is how the popliteus is released. And then once you release all the things which are described by Jignesh bhai, you can see the nice effects on the posteromedial aspect. And then you can do your temporary reduction with the clamp and K-wires. And this is how we put a plate. So this is just, disposition of saying that this approach can also be done in a supine position. And this is how up to what level you can put your plate. So whenever you are doing a posteromedial plating, I would suggest you to see the attachment of semimembranosus. because there you are supposed to reach. And if you can reach up to there, then you can have your screws right at the subchondral level. And this is how I close my popliteus, and this is how the skin is closed. So the points which are important to discuss are this: in this position, patient and anesthetist both are comfortable, and orientation of the fracture as well as the C-arm becomes easy. And many times it is a bicondylar fracture with the complexity when you cannot just finish one side and do other. So you need to do, both the jobs simultaneously. You do some temporary fixes on this side and go on other side. Those cases, a supine position alone would be very, very easy than a prone position and turning the patient. So the most difficult part, which was already discussed in the previous discussion, what is difficult? So initially learning out, sometimes it is difficult to reduce the fracture. The trick is you have to do extension of knee. You have to do at valgus of knee by keeping a small bump under the knee on the lateral aspect and do external rotation. In that view, you will be able to reduce your apex as well as the joint. Then you clamp it tight with the pointed clamp, put a K-wire, temporary K-wire through the fracture, and then you can, release the thing like, again go into flexion and put your plate. So this is where my first presentation is, a part of the presentation is over. And this is another thing which many of the people are not doing. So that's why lateral submeniscal arthrotomy you all know. But what about the medial submeniscal arthrotomy? So I am putting these three questions. Why medial submeniscal arthrotomy is required, when it is required, and how it is to be done. So I'll start with the case. This was a 40-year gentleman, had a bad proximal tibial fracture and a soft tissue injury. Soft tissues we could recover at the end of 16 days. And at 16 days, this case we took to start doing surgery. So there was a metaphyseal component, there was a medial coronal split, and there was a bad lateral fracture also. Then I did this case and I thought, oh, wonderful, I have done a beautiful reconstruction, anatomy, and everything is there. But if you look at the joint, see, my senior colleague was also to be a part of this webinar, but because of he had some other association, Dr. Rimish Patel, is nice, these arrows. See, there is a step. So there is a step in the medial tibial condyle. So this is quite often a picture. Even if you see your apex is reduced, sometimes you see a step on your medial tibial condyle. So that is the why medial submeniscal arthrotomy is also required in some cases. So when you cannot reduce your medial coronal fracture. So which type of cases you are supposed to do medial submeniscal arthrotomy? So whenever there is a coronal split, see, there are some 8 subtype of medial tibial condyle, which is described by Chang et al. In which there are some cases, like in group 1, this type 2, where this fracture line is exiting at the coronal as a coronal fracture, or in a group 2, it's a subtype 3 fracture, where you see a medial tibial condyle fractured into a coronal section. Those are the cases where you're supposed to do the medial submeniscal arthrotomy. How it is to be done, that I will show you in the next cases, but the technique is no way similar to lateral submeniscal arthrotomy, because the MCL is very tightly adherent along with the capsule on the medial side, and just underneath the MCL there is a medial meniscus. If you don't take care, you can cut easily the medial meniscus. And in this medial submeniscal reduction, we cannot see the view as good as one which is seen in lateral tibial condyle. We can see only the rim to rim reduction. So it is very much sufficient if you reduce your rim to rim along with the apex, then you will get most of the time anatomical reduction. So we'll start with a case. In this, if you see this isolated posteromedial tibial condyle with a coronal split, you can see a step on the medial tibial condyle, and this is how it is to be done. See, it is the same supine approach we had done. But at the same time, while going the posterior window, you have to go make an anterior window just anterior to the MCL. You can palpate the fracture with your finger before you cut there. Then you palpate where your fracture is. Then in the line of fibers of MCL, you gently cut and see that you are not cutting your meniscus, which is quite there. And then you will be able to see this coronal split and the step which is there. So that step you can correct under vision along with the apex reduction, and then you can do plating from the posterior aspect. Another case where you can see there is a lateral tibial condyle fracture also, and there is a medial coronal split. And again you see this is the left knee. You're seeing from the right side, and these are the hamstring tendon, and there you see the anteromedial fracture line, posteromedial condyle, and there is a meniscus just hugging the tibial condyle. And this was the pre-reduction, and this is after reduction. Then it's temporarily fixed with the K-wire, and at the end you see the plate is put on the just behind the posteromedial aspect. So these are the poster view. You can see there is a very nice reduction of medial coronal split in lateral view as well as in the AP view. So in a conclusion remarks, medial submeniscal arthrotomy should be done in a cases where there is a coronal split variety of a medial tibial condyle fracture, and to get an anatomic reduction, because many times what happens, you look at the apex only, but at the same time in a post-op X-ray you see there are double shadows. Yeah, thank you.
Thank you, Kashyap. That was
Yes, sir.
wonderful exposition of a medial submeniscal orthotomy.
Yes,
And
sir.
it is really useful when we see a double border. We can
Yes.
under vision see the things and align it and put an anterior posterior fixation device there.
Yes.
Any questions to Kashyap? Dr. Kakatkar, sir, you wanted to
Yeah.
ask some question? Yeah,
Yeah.
go ahead. Yeah.
When you are reducing the posteromedial fragment,
Yes, sir.
have you ever used the ball spikes? Because many a times holding it with a clip sometimes becomes difficult. I think Kashyap, you have to unmute.
You are mute, yeah.
I'm trying, but there is some red signal coming over the audio now.
Yeah. So I have been using a ball spike, which we use in
Yes, sir.
acetabular surgery,
Yes, sir.
and that becomes a very useful instrument to reduce that posteromedial fragment, maintain the position, and then temporarily fix it with K-wire.
Yes,
I
sir. I
don't
agree
know.
with you, sir. Yes, sir. I agree with you,
Yeah.
and that's very very good when specifically when we are doing in a prone position. But when we are doing it in supine position, it is very difficult to push it from there. In that case, a ball pointed clamp, a pointed clamp with the balls on that. So that's very easy, and that can do the same job, sir.
Okay.
In addition, Kakatkar, sir, what I do is I pass a
Hmm.
small K-wire and over that I push a cannulated punch so that it keeps it pushing, so that it doesn't slip
Yeah.
from the position.
There is
Kashyap
a
sir.
wonderful trick. Yes,
Yeah,
sir.
yeah,
Yeah.
Do
that's
you
very
recommend
useful.
sometimes pace unceremoniously release as a whole and then reattachment?
No, sir, I don't release space ever, and I even don't cut the semity and the gracilis ever. It is never required, sir. Sometime when I'm doing a posteromedial corner plating, because there are cases of a total medial tibial condyle, then I don't put my plate on the posterior surface. I put my plate on the posteromedial corner. Those are the cases I might have to release little bit of the posterior attachment of the MCL, not the pace. Pace is on the roof of the MCL. So the MCL over a posteromedial corner, little bit also only.
Okay. And what is the implant of choice you put in a supine position if you want to fix? What plate do you select to put it onto the medial condyle, posteromedial?
Almost always this posteromedial plate, sir. Almost
So
always.
you take a anatomical reconstruction plate.
Almost
and
always. Almost always.
Okay.
So previously you had a hands-on with simple buttress plate, the Alice plate.
Yeah,
or
I
something?
have been doing this posteromedial plating for 10 years now, and I have almost used every plate starting from 4.5 narrow DCP. And
Right.
with the different, if after a posteromedial plate I have to use any plate, then that will be a 4.5 narrow DCP.
Okay.
So no wrist plate, and wrist and every plates I've used.
But is it more useful to buttress with a simple plate so that it pushes well rather than an anatomical plate?
No, sir. At the same time, you get a beautiful, direction and the multiple screw choices, which are angle stable screws. There are so many advantages with that. And
Okay.
and if you have done your reduction well, you do little under contouring and then start from the distal, you gradually get a wonderful compression.
Okay, perfect, absolutely perfect. And
Sanjay
I
sir,
hope,
Kashyap sir,
Yes,
yeah,
sir.
Gadegone sir, go ahead.
now there is a trend towards the flexible small FIMD plates. Now, do you educate them or you use a standard plates?
I don't see it. It is a trend, sir.
Yeah.
I don't see it as a trend.
Pranav, any opinion on this you wanted to suggest?
Yes, sir. Two things. One is that the purpose of the plate we have to understand. If it is a large single piece posteromedial, medial condyle with a posterior apex, and we are just trying to buttress it, and it's a young patient, and we are going to put otherwise CC screws, that is the situation. I would say that using any other plate except for the anatomical plate is okay, because your primary purpose was anti-glide or primary purpose was buttressing.
Right.
But if you are using this plate for a medial condyle which is split, there is an anterior part and there is a posterior part, and you want to have a good anatomical reduction under vision, and then you are passing this buttress subchondral screws, and you want them to hold both the fragments, you want them to hold it in an angle stable way so that you can start early postoperative mobilization. So in that situation, the plate which is made for this situation, that is a posteromedial plate, is the best option.
Okay, perfect. Absolutely perfect. And now I suppose
Rajendra.
Yeah.
Another question I just had in my mind, and I have faced it once or twice when I have been doing this particular. So whenever there is a associated lateral condyle fracture also, as you have rightly said, doing it in prone position and then turning around the patient, it becomes quite clumsy. And another problem that you face is that sometimes when you have already fixed the posteromedial fragment, couple of times it happens that after making the patient supine, getting that particular condyle reduced to the lateral condyle becomes very difficult because you already passed screws into that.
Yes, sir.
So have you faced this kind of a situation, and then
many
what
times,
is the
sir.
way out on that?
Many times, sir. So whenever there is a very complex bicondylar tibia, I don't finish off one side. I'll do most of the time the medial is non-comminuted. So I'll put my medial plate, put a 1 or 2 screws, and then I will go and lateral side and finish off the lateral side. And then again I will come on that. Many times I have to do even 3 steps. I have to start from the lateral. When I expect a meniscal entrapment on the lateral aspect, I start with my lateral approach, remove my meniscal entrapment, do my medial job halfway, then again go on lateral side, finish off the job, and do my medial job complete. So it's always that, but that pre-op planning has to be done on a CT, and on table you are just supposed to follow your plan, which is made pre-operative.
Sir,
In those cases,
can I
it
say
would
something?
help.
Sir, can I say something?
Yeah, go ahead, Jignesh.
Yes.
Sir, bicondylar tibia fractures, see, you have to plan your screws. You know what you are going to put an implant. So you can always leave 7-8 millimeter space proximally on medial side, and your rough screw will not hit the medial side. So you put a plate accordingly that your screw will definitely not hit the medial screws which are going from posterior to anterior. So because see, there are not much of the choices of the screw in a rough plate and the posteromedial plate. So you can just plan your plate position and you can just get away without any problems. By and large, doesn't hit. By and large, it doesn't hit.
Right.
If you plan your space properly right from beginning.
Good evening and welcome, Tanna sir. Tanna sir has joined. So we welcome Tanna sir for this discussion on proximal tibial approaches. We had 2 lectures, sir, so far on posteromedial approach and the posterolateral fixation by Jignesh.
You started at 5 o'clock or 5:30?
Yeah, 5 o'clock we started, sir.
5 o'clock.
5 o'clock. 5 o'clock.
5 o'clock?
Yeah, 5 o'clock we started.
Mara information 5:30 ka tha. Anyway.
Good evening, sir. Jignesh Pandya.
Good evening. Good evening.
Good evening. Yeah.
Good evening, sir.
Guruji, namaskar.
Hi, Vijay.
Hi.
Good evening, sir.
Good evening.
Yeah. So now I think Dr. Sanjay Sarvaiya is ready with his presentation. He's sorted out with his audio and video as well. Please proceed, sir. So he's talking on anterior midline approach.
Hello, good evening and greetings from the city of Bhavnagar. I thank all the organizers for giving me this opportunity to present myself. And I really say sorry because there was some technical problem and I could not connect. So I will be talking on anterior midline approach for proximal tibia. If you see 360-degree dissection of the proximal tibia, probably I'll start at 0 degree longitude. That will be anterior midline approach. So you have a case like this. The patient has been operated with this dual incision. You know the blood supply in the skin of the anterior region is predominantly from medial to the lateral area. And then after 2 approaches, the blood supply between these 2 incisions gets interrupted. Now, if you want to go for a TKR and the patient develops arthritis, probably the 3rd incision for knee arthroplasty could result in necrosis of the flaps between the incision. Whereas if you have such a case, where anterior midline approach has been taken, and the patient, elderly gentleman, if he requires arthroplasty in near future, probably the things would be easy, the things would heal well. So anterior midline approach, there is better visualization of the plateau fracture geometry, and there is fracture reduction, accuracy of the fracture reduction. The direct assessment of the chondral surface, meniscus, and cruciate ligaments. No neurovascular risk. Same incision used for tibia that we have already discussed. Less need for fluoroscopy, and you have option for 2 plates on either side. There are very good articles and few papers from South Korea. They have described this as a viable treatment for Schatzker type 5 and 6 tibial plateau fractures. And another from Europe, where they've used a extensile anterior approach for central depression, ACL avulsion, and tibial spine fractures. Along with the proximal tibia fractures, they have also, through this approach, done open reduction. So mainly I will be discussing these 4 indications: Schatzker type 5 and 6 fractures, but not much of a posterior combination, posterior involvement. Then useful to treat the depressed central fragment, tibial spine fracture, and cruciate ligament avulsion, and hyperextensional bicondylar tibial plateau fractures. Probably this is the best approach where you can approach these fractures. And floating knee injuries, that is actually a relative indication. So, but there are limitations. You have a limitation of placing a posterior plate. And initially there were increased rate of infection and skin necrosis. But the recent studies, we have just compared these 3 studies, where 2 studies shows that there's no infection and no wound problem with the anterior approach. Whereas with the dual approach, it is 8.4%. This is due to the good result because there is delayed timing of surgery and use of temporary spanning fixator. So you have better assessment of the soft tissue. And once the soft tissue heal, probably after 10 days, if you go for this, you don't have much complications or infection or skin necrosis. As you can see, this patient, this has a posterior apex, and you cannot do anterior midline approach in this fracture. And this has to be done by a dual approach, as already discussed. As you see, initially there were a lot of problems of skin necrosis. And once the bone gets exposed, it is dead. No flap can cover the bone. And you require resection of the bone, and you have to go for Alizaro. But if you see this case, you study the CT properly, there's a large medial fragment, medial condyle, and there's a lateral depression with a central fragment. So this can be better assessed with anterior midline approach. And this is the stepwise how we do it. Just from the patella, you start, you go straight, be little lateral to the tibial tuberosity, and just follow the shin of the tibia. And then you raise a thick flap. Don't undermine the skin. You have to raise the lateral flap and the medial flap. And after that, you have these landmarks. That's the patellar tendon, the medial collateral ligament, that's the IT band, tibial tuberosity, and the shaft of the tibia. This is the exposure which you get. And you need to know your limitations. Just be anterior to the tibial collateral ligament and fibular head. You cannot go behind that. So your all dissection will be in this limit only. And then the first step, you go medially. And just below the pes ancillaris, you fill the posterior medial border of the tibia and remove any soft tissue or any periosteum which is interposed in between the fracture fragments. And then you reduce it first. That is the first step. You reduce with the ball spike clamp that what Dr. Vijay sir was just discussing. And once you have done that, you just fix with temporary K wires. And after that, you go for the articular reduction. And articular reduction also use another clamp. And then just temporarily fix with the K wires. And then your option, but I would always go for a medial plate first. And there can be some tips and tricks. You can do anterolateral arthrotomy if it is required, or submeniscal arthrotomy, submeniscal meniscectomy, or you can just go medially also. And medially also you can do arthrotomy. And you can use these step incisions just to put the posterior screw. And these are the intraoperative pictures. This is what how it looks. And then you can close the wound over a drain. So we were discussing this case. The case has been just reduced like this. And then you have this sort of fixation. And always you compare the medial plateau tibial angle and the posterior tibial slope that you have to compare, and it is normal here. So this is a beautiful healing. You can see the result, and that's the video. You can see the patient is walking nicely. But then you have some situations, which is a high energy medial shear fracture, where there's central depression, the lateral meniscus has been interposed, and this is a fracture dislocation. And again, this is a very recent paper. This is, I think, in 2020, May 2020, where they have said that anterior midline incision is safe and effective approach for high energy medial shear fractures of the tibial plateau. And here, Perry has described in 1982 an extensive midline approach. And we can see that the patient is in supine position with 90 degree of flexion. Then you incise the subcutaneous tissue and muscle fascia as a whole, and you take a parapatellar incision, and then you identify this structure. So that's the transverse intermeniscal ligament. This is besides the ACL. You elevate the anterior horn of meniscus. The meniscus capsule and the periosteum is lifted, and the patella retracted laterally. And after do 90 degree of flexion, you get the whole exposure of the tibial plateau. And you can see the chondral structures, the ligament, the depressed fragments, the aversion fracture, and accordingly you can treat that. And another approach now is described is the medial epicondyle osteotomy, probably in that, but you don't get this exposure in that approach. And then you can close the wound. And you can see through this approach, the same thing has been, how beautifully the central depression has been reduced. You get a beautiful healing of the wound. That's the final result. And that's the video. Sorry, the video is not playing. Okay, it's playing. Another patient. This patient actually, it was before 15 years when there was no CT scan here in my town, and I could not do a CT scan, but I just took lateral X-rays and the oblique X-rays. And this is a very bad, nasty injury. And there you can see that the ACL also is involved, and the tibial spine is fractured. So this is what we had done. Through the midline approach, we get a window, we did a lateral arthrotomy. Through that, we could just find out where the tibial spine fracture was. And through the pull-out stitches to the bone, we could pull that ACL fragment, ACL eversion to the bone. And you can see the beautiful healing at 1 year. The patient is comfortable, the wound is healed well. But then you have a patient like this. If you see, there's a central depression, the lateral plateau is depressed, and there's a big void. And this is a beautiful instrument, and Dr. Kashyap has devised this instrument, and he has popularized this instrument. So you can take the peg graph from the distal end of the femur, and this peg graph just takes hardly 5 minutes. And these peg graphs can be inserted in the void, and then you can see the patient beautiful healing. In proximal tibia, always use 2 plates when there is a comminution, because a single plate is not going to give the results. This plate has failed. So then we had to be revised by another plate and bone grafting. So such a bad injury, but treated with, this was just before 15 years. So no CT, and we had used the conventional plates. But you can see a very good result. This patient also, we had used conventional plates, but now with these modern plates, you can use a small plate on the medial side. This patient, if you assess this from the X-ray itself, you know that there's a large medial condyle. And the thing which I was describing is you go through a midline approach, you reduce the medial part first, and then everything will fall into place. And this is what has been done. And if you feel that the medial plate doesn't give much support to the posteromedial side, this is a kickstand screw. And you can add other screw just from outside the plate. So these 2 screws, if they go from anterolateral to the posteromedial direction, it will give enough support to the posteromedial side, because it is a single piece. There is no coronal split or no coronal fracture. Another patient, this was operated, and you can see that the tibial tuberosity fracture has to be put into place. This fracture, the patient comes around at 10 o'clock in the morning, and then you have a window period of 4 to 6 hours. And you can take this patient directly to the OT. This patient was operated within 4 to 6 hours. And you can see once you reduce the fracture, you evacuate the hematoma, you put the protruding pieces into place, and you can just fix it. So this was done within 6 hours, and everything had healed well. This patient compound grade 2 fracture. Again, this patient also, if it comes in the OPD hours, and you can end the OT in the afternoon, you should take it within 6 hours. And the small plate and a larger plate, but you can see that a beautiful anatomic reconstruction and no problem with the healing. This patient also, when there's a large fragment, put a large plate on the medial side where the large fragment is there, and a smaller plate on the lateral side. This was in August 2011. At that time, we had to give just STP traction for 7 days and then operate. But now in July 2020, as sir was discussing, you span, scan, and plane. So the first is, I just put the external fixator emergency term in my OT. So this patient comes, we first put external fixator. This is what is done. And now we advocate putting the fixator anteriorly, so that in somewhat of 10 degree of flexion and dissect the fracture. And nothing else is to be required, and let the patient go home the second day. So the economically also, it will be cheap to the patient. They can go home, they can come after 10 days. You get a CT scan meanwhile, and from the CT scan, you know where the fragments are and from where you want to approach and where you want to attack first. And you can see that this patient has been operated with this dual plate. The beautiful healing, and at 3 months, the things are going well. This patient, actually, there is a lot of crushing of the bone. There is metaphyseal extension, and he develops a lot of blisters. So our principle to put the fixator would be, you just identify the zone of injury, the zone where your definitive fixation would come, and then put your pins away from that area. For this, you have to put your pins just away from the suprapatellar pouch and away distally where your plate would end. So you put a fixator like that. Initially, we used to put this fixator in this plane, but now we have changed to the anterior fixator. And here no fasciotomy was done, but still the wound had healed within 14 days. And then there's the second stage fixation, which was done after 14 days. And you can see the healed blisters, and at 1 year follow-up, everything has healed well, no skin problems. So this patient, there is extensive contusion of the skin, lot of blisters, and this patient would require a fasciotomy because the compartment was an impending compartment, and the compartment not established, but we would do a prophylactically release of the lateral side. So you know the knowledge about the compartments. These are the 4 compartments: anterior, lateral, then the deep posterior and superficial posterior, and you require 2 incisions, the anterolateral and the posteromedial. But in this case, you can go through just one approach, that's the parafibular dermatofasciotomy, and just go little posterior to the fibula, and you can release all the 4 compartments and just leave the skin like that. And after a few days, if you feel, you can do a skin graft. And this is what was done. And just you can wait. This may take about a long time. It may take about 3 weeks, but within 3 weeks, you should go for a definitive fixation. Otherwise, the pin tracks start getting infected. So this was operated after 18 days. And you can see that everything is healed, and the skin graft has also taken up very well. This patient, a very bad injury, so a prophylactically lateral fasciotomy was done, and you can see there's an anterior wound. So what we planned is after a few days we could close the wound. So while you go for the second operation, there's no serious discharge, and give some time. And since there's the anterior wound, we decided not to go for an anterior midline approach, and we fixed this fracture. And then we had gone for the anterolateral and the posteromedial approach. And you can see that even that wound, which was there over the tibial tuberosity, that has healed very well. So we have discussed these few indications. Now we would be discussing hyperextension injuries and the floating knee injuries. So this is a floating knee injury, and this patient has to be operated urgently. So we started with the femur, and then the femur was operated in time within, I think, 1 or 2 hours. It was complete. And then we just went there and extended the approach, and the anterior midline approach was taken. And you can see that things have healed well. This is a recent article in 2019, and when there's this bicondylar hyperextension injury, probably this fracture, this midline approach, you can approach the fracture, you can have a proper assessment of the fracture, and it gives the best exposure. This is from the literature. There they have done a tibial tuberosity osteotomy, and once you just flip off the tibial tuberosity, everything is in front of you. But the extension injuries may require a bone graft, and then it has been fixed with 2 plates. But this is just from the literature. This is my case. This is a hyperextension injury, and you can see that everything is in front. There is nothing posteriorly. Here the patellar tendon was also torn, but there are a lot of ecchymosis around the infrapatellar region and tense skin. So temporary external fixator is always the best option. So waited for 10 days and then we went for a midline approach. And this is how we approach it. This you can see that we put these 2 plates and just with Ethibond sutures, we could suture the torn patellar tendon to the plate and the bone. And then you can see the posterior tibial slope angle and the medial plateau tibial angle has been restored well. And you see that the kickstand screw is providing proper support to the posteromedial side also. And then again supported by the medial plate. This patient, a very interesting story. He's a 22 years old male, and he just got engaged. And just he was returning from his engagement ceremony, and he had this fracture. So looking to this deformity, the relatives are very much worried. The more worried were his in-laws. I just took a traction view, and then through a midline approach, I did this. And you can see excellent result. And then after 1 year, the relatives, they came to me, he was married and they were very happy. He said that now he doesn't have any deformity. He's walking nicely and thank you. Points to remember, good results with delayed timing of surgery and use of temporary spanning external fixator. Must lift the subdermal tissues and muscle fascia as a whole. The parapatellar arthrotomy can be useful to treat depressed central fragments. We have already discussed, and tibial spine fractures and cruciate ligament avulsions. And we could conclude that simple and familiar for orthopedic surgeons. We all are doing TKR now, and it is very, very simple to all of us. Offers good visualization and simplifies reduction. Provides a functional scar if necessary, procedures necessary. If functional scar, if further procedures necessary. But you have to assess the CT scan, the skin condition, and then only you can plan this approach. Otherwise, whatever has been discussed, you should go for those approaches. And there's limitation of putting a posterior plate. Thank you.
Thank you, Dr. Sarvaiya, for wonderful exposition of the anterior approach and its indication and usefulness. Any opinion, any comment from the faculty members? Dr. Kakatkar, are you still using anterior approach in some cases?
Yeah, in some of them I still use, especially if there is not much of a posterior depression of posteromedial fragment. Then sometimes I still use this approach and I am able to get screw anteroposterior as a lag screw if there is a big fragment on the posterior side which is not much displaced. And it gives very good stability. We can mobilize them quickly and it gives excellent function.
Tanna sir, your experience on this approach, and now have you shifted to MIPO completely?
See, I think to start with, this was the only approach.
Yes.
And I think the whole diagnosis was not done of the posterior segments.
Right.
But today it is restricted to a very small subset of fractures, which probably Sanjay has mentioned about it, that when there is no posterior element, there is no posterior lateral, there is no posterior medial, then only this can be done. But I feel, to me, nowadays, I don't do this anterior approach as such. Because if at all it is needed, it's a medial or lateral. Because even if you don't want to need a posterior approach, because then by and large, it is a MIPO approach most of the time. So this bang anterior, like this, it is, to me, it is a past. I don't do it anymore.
Dr. Gadegone, are you using this approach?
No. I don't use. I use a double approach. I was using initially, but I had a very bad experience of this approach in extensive bilateral plating. Sanjay has a good result because probably he is doing in a better way. But Sanjay ji, I want to ask one question. You said that it should be taken within 6 hours in emergency in such a bicondylar fracture.
Sir, I would clarify. Only for few patients where it was irreducible fracture reduction. The fracture could not be reduced by STPin or external fixator, and there were rotating pieces where the central pieces just below the tibial tuberosity or the tuberosity itself, which was protecting into the skin.
Risk to vessels was there in those cases.
So within 6 hours, if you are able to do that, you can evacuate the hematoma, you can put things together, and the skin will also heal by itself. But yeah, if it is blisters you see, then you wait for 10 days and just put a fixator. But after putting a fixator, then things become easy after 10 days. And I am doing this only in 30 to 40% of the patients. I also shifted to bilateral approach. These are very old cases, but still in some cases, this may be an indication. That is what I'm trying to
yes.
say. You have a CT
Yes.
scan, you just...
in some of the cases, especially when there is a avulsion of the anterior.
You can do it. And when the tibial tuberosity is involved, or there's a diaphyseal fracture, there's a central diaphyseal fracture, that can be reduced very well, because unless and until you reduce the diaphysis in the metaphysis, you cannot align it to the proximal tibia, to the interarticular tibia.
Okay.
All right, I want to introduce one controversy. Scan and scan,
Plan and
Scan,
plan and
scan and then fix.
And then
yeah.
now that means the X-fix becomes the mandatory treatment for all these fractures, where you expect edema, skin bully, and everything. Anybody doing without the X-fix, just waiting it for 10 days or 8 days? Because I don't put an X-fix.
yes, sir.
I don't put an X-fix.
I don't
I
put
feel in my setup to get a theater right on time, I'll have to go and work at about night to put the X-fix. And because I work in a corporate hospitals, and X-fix means about 1.5 lakh, 2 lakhs rupees for the patient extra. And I find personally, it doesn't add anything. So I put it only maximum at times. I put it if it was the tibial traction from distal end of the tibia, or otherwise nothing. Just elevate it, and go down. And I haven't found any problem. Any of the opinions of the other? I think because I see many hands coming up.
Yes,
Vijay?
Yeah.
What about the lateral fasciotomy? Lateral fasciotomy, does it help? Because if you do a lateral fasciotomy, just cut the fascia and leave the skin like that, the things would improve in no time. So what about the lateral fasciotomy?
No, I haven't been doing it.
Dr. Sarvaiya, you did it in some patient? Only fasciotomy, holding on for 10 days, and then fixation?
Yes, sir. Yes, sir. This is what I have shown.
Okay.
I have one small case for panel discussion. Can I put up, or shall we do afterwards?
Yeah.
We'll just,
Let us have a case from Tanna sir first, and then we'll have your case.
And I don't have to share the screen, so it will go with this.
Yeah, okay. Okay, then you can share. No problem.
Put up one case.
Sure.
Yeah, technically also.
For the faculty members, you have this patient. He's 62 years old, road traffic accident. He's a non-smoker, non-diabetic, quite healthy. And he has this anterior wound and a posterior wound. And this is the fracture. So how would you approach, sir? Dr. Chandak, sir, we start with you.
Yeah. To me, I would, of course, ascertaining the vascularity, and if that is well maintained. So debridement of all these wounds, and then planning a X-fix suitably, and then giving a vac if the vessel and bleeding is not an issue. So I'll initially optimize the wound by vac, soft tissue closure, and then think of fixation. That would be my philosophy for this patient. No day one fixation with plates.
just the Chandak sir.
Yeah.
When you do it in under anesthesia for some time, doing external fixator and debridement, why not to align the articular surface and you have a temporary fixation with K-wire or some CC screw?
I would agree with that, creating an artificial metaphyseal block or the articular block by minimally invasive K-wires, that would always be combined in such patients.
Okay.
Yeah, that's, I think, very important.
Yeah.
Chandak, with your permission, can I go back to my question again?
Yes, sir, please.
I think I saw many people raising the hands, and we are, since it is not being done, we are bypassing it.
Yes, sir.
Dr. Vijay, I think you raised your hand that you don't put an X-ray. And even Dr. Kashyap put it.
Yes, sir.
Yes,
I put it in only 1 in 20 case.
Yes, any?
Well, I have been using X-fix only if there is a compound injury. but otherwise I don't use X-Fix at all. So I do scan, but then I don't span before scanning. What I do is to get the edema down, I aspirate the hemarthrosis, and with the same needle, I make multiple punctures up to fascia level in the upper part of the tibia, and then put the patient either in a slab or traction, as you rightly said. And then I have hardly ever seen a blister coming. I don't know anyone of you has tried this, multiple punctures with the same needle. You use an 18 gauge needle for aspirating the hemarthrosis, which reduces the tension from the joint. And with the same needle, I just make a couple of punctures up to fascia. You get that feeling that your needle is piercing the fascia, and that reduces the pressure. And I have not seen blisters in fresh coming cases in last many years.
So are you actually completing the fasciotomy with needle with multiple sites?
Yeah, I just make multiple punctures onto the upper part of the tibia where you expect blisters to come, and then just put the patient on traction.
Does it ooze thereafter? Does it ooze those punctures?
In the first 24 hours, actually, the gamgeo on that particular area number of times gets completely soaked. And it is not just blood, you get a lot of edema fluid.
Are you not worried about puncturing the skin, which is a barrier to skin, sir?
No, but then, you are already giving an antibiotic cover. So within next 2 days, when all these punctures, they heal. And as it is, you have to wait for at least a week for all these bad fractures for doing a definitive fixation. But then the problem of...
Yeah, coming to Tanna sir, your suggestion about the back slab. Now, most of the times we are putting a back slab, not a very tight plaster, with a fiber back slab, and observing, say, after 48 hours, even if the blisters come, we just dress them, just put a gamgee roll with soaked betadine, that's all, in longitudinal fashion, no circumferential tight bandages, good elevation, not on a bolus print where the foot is inclined, the foot is lower than the knee. So it is a good elevation, active pumping by patient, and anti-edema measures. That helps. Two important things: we avoid a pin track, which is at times a nuisance with the pin track. So, but very unstable fractures where vascular impediment may happen, a posterior spike may go, is the place where I would put X-Fix. So one in only 20, as you said.
Sir, I think we are discussing the cases where there is a lot of metaphyseal comminution and the proximal tibia, the crux of today's discussion, which is the proximal tibia intra-articular. Probably we are bypassing it. I have rarely seen a simple proximal tibia intra-articular bicondylar or joint depression type of fracture with so much of comminution and so much of extension into the shaft. So as Kashyap bhai rightly said, probably 1 in 30 cases we require external fixator just because we are worried about the soft tissue. And most of the times within a week or within 10 days or maximum within 14 days, we are able to go ahead and just finish off our intra-articular job.
Right. Rightly pointed.
We have already introduced some small controversy. We can proceed now.
Right.
Through the wound, it was a clean wound. So through the wound, the first thing is that you reduce the intra-articular part, and then with 1 K wire, this is where your kickstand screw goes from anteromedial to anterolateral to posteromedial. And then just through a MIPO, you can see that small transverse just at the joint line. I introduced this plate, right? And just that bridge of skin was intact. So it was passed medially, and then 2 screws could be fixed. And the posterior wound could be, we just took the Weichler sutures and did not stitch the skin. So this is how the situation is at 3 weeks. So the proximal part has been fixed well. You can see both the angles, medial plateau tibial angle, the posterior slope. And then you have this thing, and this is the wound. So now what? So I was planning that at least I could do a MIPO plating by lateral side, but then I did not take a chance because the skin would probably give away. But see what nature has in store for us. So this was, I shifted to Alizaro, and this is the skin after doing Alizaro, but still I did not do anything, just dry dressing. And you can see after 2 months, that swab of skin. So don't remove that skin, you put it, it will granulate, and see how the wound has healed. So this is the healing of the wound. And you can see the posterior wound also, that is healed, and patient has started walking. So I planned for plating, but then of course some situations you don't take a risk, because we generally in a small town, the plastic surgeon is not available and the treatment of plastic surgery becomes very, very expensive. So Alizaro, this simple frame, probably all average orthopedic surgeons can do in their nursing home. And this is now about 2.5 months or so. The patient is walking, but just from the panel, what future should I do? Should I do a bone grafting or should I switch to plate? Because this is the wound now. Tanna sir. This is the last slide.
I think it will need a bone graft at some stage.
Okay. Should I keep the frame on or just switch to plate now?
Alizaro is remaining there for a long time. I am not in favor of that. I think it should be very Alizaro or anything what we do here for such a fracture is temporary measure. You can just put in the bone graft and put in a long plate.
Chandak sir.
Now basically the initial worry about skin conditions and everything is gone.
Vijay sir.
Yeah, I think if you have already put plate on the medial side and then put an Alizaro, I think there is a very high risk that you can introduce infection. So I wouldn't keep Alizaro for a long time. I think I would go in, remove the Alizaro, give some time for the pin tracks to heal, and then go ahead and do a plating.
Kashyap bhai.
I see there are two options. The one option is, this was actually the part is quite in a diaphysis. Those cortical bone, multiply fractured, almost have lost their vascularity. So probably even after grafting, there are issues going to be there. So I would call a Alizaro surgeon who would resect the middle part, the comminuted part, create a gap of say 3 to 4, 5 centimeters, then do a distal corticotomy and transfer on the same frame.
No, it is vascular. Bone is vascular. Bone is attached soft tissue with it, periosteum with it. This is all vascular.
But still, in a diaphyseal comminution fracture, they doesn't throw callus very well. We have seen it quite often.
This is 2 months.
Segment transport for this, it will be very dicey, Kashyap. I feel it will. It has a potential to allow.
Okay, sir.
I think it is too simple operation. You are making it more complicated. This is how my opinion is, sir.
Okay.
Value of a posteromedial plate and a graft posteromedially.
You put the plate into the safe skin zone.
Yeah.
Now there are no chances of breakdown of the skin. So if you go for a lateral plate just by MIPO, you can put a lateral plate, long plate, and graft, as you mentioned, you can go through posteromedial.
Now this Alizaro is there for how long?
2 months.
It's 2 months, 2 months.
Yeah, so 2 months, the chances of pin track infections and the secondary infections.
See, one thing I've done, we have not noticed, sir, but I have just put a rush pin into the fibula. That has given a very good stability, because this was a rotational injury. And the thing which I forgot to mention was that I had done a fibula nailing. Can I go back?
Yeah, it is seen there.
It is seen there.
So that has given a very good stability.
Yeah.
The fibula has given a very good stability. So in this case, the fibula wiring was done.
Okay. Are you selling us? Now I'll be a little more aggressive. Are you telling us that the small piddly little nail which you put in fibula is giving you a solid stability?
No, not solid stability. Sir,
what?
not solid stability. It cannot give. It cannot give. But it is maintaining the length. It is maintaining.
That's not what he's doing. Nothing else.
What Dr. Kashyap's
It has nothing to do with
said.
stability. Do you agree, Sanjay? It has nothing to do with stability.
No, not stability, sir. But at least when you put it in place, there is some sort of rotation stability. That
length and alignment will be.
Yeah, that we all agree.
If bone transport is there, probably things would be easy. Because all the possibilities may be there. When we started, we had all possibilities of the skin getting necrosed, the bone getting infected. Everything was there. But now the things are as such.
Now, what has happened afterwards? You have the follow-up or no?
This is 8 December X-ray, just before 10 days only. So let us see. I have given him 1 month, and then I'll take another X-ray. Then wait for
This is typical. After a foreplay, you are letting it go.
Okay. With that good case, we come for the.
Chandak sir.
Yeah.
Sanjay, did you open the fibular fracture fixation?
Yes, I had to open, sir. I had to open.
So you have created a new incision there already because it was a mostly, if you see, it's an undisplaced fracture.
No, sir. It is not undisplaced fracture. It is not undisplaced fracture, sir.
So I think we'll have to move on. We'll have to move on to the next lecture. So please, Dr. Kashyap, can you share your screen?
Yeah. Should I go ahead with?
Yeah, go ahead with your screen. Yeah. And after that, your lecture, Dr. Pranav Shah would be having his lecture.
So I have 2 talks. Should I continue it or I have to break it between? Because there is a one.
Continue.
Okay, sir.
Continue. So you make it concise, and then we have Dr.
Yes,
Pranav Shah case. Then we'll have Dr. Tanna sir's case.
No, I think what I would suggest is you let everybody else talk. If there is time enough, I'll give the case.
Okay, sir.
No point in me doing it.
Yeah.
Is my screen visible, sir?
Yeah, it is visible. But I think the bandwidth is less. Yeah, please go ahead. Start.
Okay. So I'll on the anterolateral to lateral fractures. If we will briefly takes a few points.
Just a minute, sir. I think I'm not able to see the screen properly, and I'm even hearing the voice cracked out. Is it the same with everyone?
Yeah, it is same. And I've stopped this video so that we get his remaining bandwidth for the presentation.
Yeah. Okay.
Yeah. Yeah, you continue. Please continue.
Okay. Look at view of the proximal tibia with menisci. The meniscus is actually smaller than the medial meniscus. So it is having more force injury. So much useful because when there is a lateral condyle, the chance injury meniscus, then injury meniscus in a tibial condyle fracture. And few other points.
I think we are having a real trouble with your bandwidth. Yeah.
Okay. Okay. So in a medial tibial, if we look, it's a coronal fracture, and lateral, if we sorry.
Still, we are not able to see properly.
Okay. Stop sharing, and I'll let the other presenters continue.
Yeah. By that time, you can sort out your.
Yes, sir. I'll do that.
Yeah. Pranav, can we have your lecture? Pranav? Please unmute yourself, Pranav.
Yeah.
Yeah, please share your screen. By the time Kashyap gets his bandwidth back, I think we'll have your lecture. And all would be eager to listen to a Frosch approach. And I suppose you will be talking on Frosch approach. Yeah, we can see the screen very nicely. Perfect. Absolutely.
Okay. Yeah. So I thank Dr. Chandak and all the expert panel to give me this opportunity to talk about this Frosch approach. And we start with this simple case. She's a 26-year-old female, had a road traffic accident. It was closed fracture. There is no medial tenderness, no medial bruise. These are our X-rays, AP lateral and oblique. As we all can see, there is a lateral condyle fracture. The CT scan shows at least two, one anterolateral and one posterolateral fragments. The posterolateral looks to be a bigger fragment. And if we observe the lateral X-ray more closely, we can see that the articular surface has depressed in such a way that the joint surface is facing anteriorly. It is probably 70 degrees rotated. The same patient, we are seeing coronal CT scan, which shows that the major fragment is the posterolateral piece, which is probably accounting for 70% of the lateral condyle. And then the coronal sections also show that the posterolateral fragment is significantly large, and we can see that it is abutting to the head of the fibula. The fragment has displaced posteriorly and it is wedged between the intact proximal fibula and tibia. And on the sagittal CT scan, we can also see an element of intercondylar fracture. Probably it looks like undisplaced or minimally displaced, but on 3D CT scan, we can see the intercondylar fracture. So, summary of our case is that it's a lateral condyle fracture. There is a medial condyle which is intact. MCL clinically is intact. There is comminution. So we have at least three pieces, anterior intercondylar piece. Then we have the lateral condylar wafer thin like piece over here. And we have a large piece over here. And the purpose of our approach, what we have to get from our approach is we should be able to visualize all the three fragments, and we should be able to reduce simultaneously, each in relation to the other. The intra-articular reduction should be preferably under vision, and posterolateral exposure most likely will be necessary to reduce, manipulate the large fragment, and maybe fix it from behind if necessary. So we now need our anterolateral approach to fix a strong implant, because we don't have a strong implant from the posterolateral side, but we also need a posterolateral approach for reduction. So the combination of the two, the posterolateral as well as anterolateral, that is what we get as a Frosch approach. And it is nothing but 1 + 1 = 2. So if you can do a posterolateral, if you do anterolateral, then you do a Frosch approach. The incision is somewhat in between the two. We have an anterior and a posterior window, the anterolateral arthrotomy done here and the posterolateral work done over here. The head of the fibula is the most important landmark. And the purpose that this approach was devised was because previously the head of the fibula osteotomy was done to expose the entire lateral condyle, and it was found to be very damaging, and there were a lot of problems with fibular head osteotomies, including the peroneal nerve involvement. So preserving the lateral collateral ligament and biceps femoris attachment, we can approach the entire condyle with this Frosch approach. Important anatomical landmarks here. First and foremost, we have to understand this is the X-ray being seen. I mean, this is a knee seen from behind. The two important muscles that we will be encountering posteriorly will be the popliteus muscle and the soleus muscle. And this is the area from where the soleus will be erased downwards. And once that is done, we will be encountering a medial geniculate vessel, most likely the lateral inferior medial geniculate vessel over here, which may require cauterization or ligation. So in a nutshell, this is how the posterolateral window will be from anatomical point of view. The important thing here, the important caveat here is the anterior tibial vessels, which are going to start from the popliteal vessels and enter into the anterior interosseous, anterior into anterior compartment from the interosseous space. So if we look at the posterior view of the knee, this is the general depiction of the anterior interosseous, anterior tibial vessels, how they start from the popliteal vessels. So over here, if this is how the popliteal vessel would be located with the retractors in place, this is where the anterior tibial vessels will be crossing obliquely into the anterior interosseous space, and we have to be sure that we don't damage them. On an anatomical specimen, on a dissection specimen, this is where that anterior tibial vessels will be in relation to the head of the fibula. And in a clinical scenario, in the operative theater, this is where those anterior tibial vessels are. This is our posterolateral window. This is the anterior tibial vessel, and this limits our distal extension of the posterolateral window. So now let's start. This is a patient in a lateral position. These anatomical landmarks have been marked. The head of the fibula is the most important landmark. We as surgeons are standing behind the patient. The patient is on a radiolucent table. There is a bolster beneath the knee, which already exists a varus strain so that the lateral joint can be visualized better. The incision is a linear incision along the level of fibula. The fibular head is our landmark. We start 4 centimeters proximal to the joint line and go distally along the fibular shaft like this. It's a linear long straight incision. And we make sure that we raise both the flaps thick. The thick flaps, because we don't want wound necrosis. These are long incisions. This is the extensile approach. So make sure that we don't, we don't affect the vascularity of our skin flaps. The most important structure to be identified immediately after the skin incision and raising the flaps is the peroneal nerve. And it is quite superficial. And so we have to be very careful that we don't damage the peroneal nerve. As you can see, it has been highlighted in this picture. Now there are 2 steps in the Frosch approach. First step is the anterolateral window, which is the classic anterolateral approach, which we do by splitting the iliotibial band. We do the submeniscal arthrotomy to visualize the articular surface. So in this picture, this is the front portion, the patella, the femur, the leg. This is our anterolateral arthrotomy. If I zoom it, this is how it looks. So this is the meniscus. You can use sutures and retract the meniscus to have a better visualization. You already have a varus strain because of the bolster beneath the medial side, and you can just clean out the joint and then you can inspect the articular surface and you will be able to see most of the articular surface. The important point I want to highlight here is that the usually lateral condyle or anterolateral portion of that lateral condyle is a very thin wafer-like structure. And if we erase all the soft tissues from it, then it becomes avascular. So we should minimize the soft tissue stripping from the anterolateral condyle fragment. Now we go to the posterolateral side. So the anterolateral arthrotomy, as you can see over here, is already done. Now we are going to the posterolateral part, and the peroneal nerve is our lighthouse. It is the most important landmark. We have to identify the peroneal nerve, and then everything else begins from there. So once we have cut the deep fascia posterolaterally and the peroneal nerve already being protected while cutting the deep fascia, we will be seeing the lateral head of gastrocnemius, which in this has been retracted with the retractor so that the muscles underneath are visualized. And what are they? The important muscle here is the popliteus muscle, which is this, the popliteus with its tendon. And the second important muscle here is the soleus muscle, which has been cut from this area. This is our fibular head. So from the fibular head posteriorly, just behind the peroneal nerve, and we start cutting the soleus muscle and we erase it downwards. How much? Till we reach the anterior tibial vessels. So this is how we do the posterolateral window, and then we can see the posterolateral fragment very clearly from our posterolateral window. Now once that posterolateral fragment has been visualized, we have to do the reduction. Now reduction is done from the front because we have to lift from the front. But you can see here that I have used a spike to push from behind because the posterior soft tissue hinge is broken. And by elevating this, we also need to push it into the front. So I am disengaging. If you correlate with the CT scan, this is our condyle, the major posterolateral piece facing in the front. This is our anterolateral, this piece, which is being opened by using open book sort of maneuver so that the condyle is very well visualized. And before we try to elevate, try to get as much bone as possible with the articular fragment. So this, I am elevating the articular fragment. And as you all can see, it has been elevated with a large chunk of bone. There is a pressure from behind with my spike so that the fragment doesn't push posteriorly. And the elastic recoil of the proximal fibula also helps to push the fragment in the front. As you also can make out, I have hardly erased any periosteum from the anterolateral fragment, if all of you can make out over here. So moving forward, let us see how it looks on the X-ray. So this was the pre-surgery X-ray. Unfortunately, you can see the intercondylar fragment has displaced slightly. And this is the view after reduction. So now you can see that this fragment has been elevated well. And in the AP view, you can see the perfect profile of the posterolateral fragment and the lateral condyle fragment here. And you can make out the margins of the meniscus. So provisional fixation with the K wire, and then we go ahead to put the plate. But we also need to make sure that posterolateral to anterolateral fragment is held with the pointed clamp. So the posterior prong is from the posteral window, the anterior prong is from the anterior window, and this is how the plate has been put. Apart from that, the intercondylar fragment also can be visualized from your anterolateral arthrotomy. So it has been reduced and it has been fixed provisionally with a K wire, and I'm going to put a screw subsequently into it. So moving ahead with the fixation, the reduction is confirmed in multiple views, and then the fixation is done this way. The fixation is straightforward. You can see that 3 of the 4 raft screws are engaging the posterolateral fragment. So I did not put a posterolateral plate because it was a large fragment. It was very well held with the raft plate, and the raft plate is significantly strong plate. So I have just put a single raft plate. Before closure, this is how things look. This is our anterolateral arthrotomy over here, an anterior split to take the plate. But you can see that this portion, the anterior portion of the lateral condyle has not been stripped from the periosteum. It is extra periosteal plate that I have put in this patient. A close view, and you can also see the intercondylar piece which was held with the screw. And after closure, the arthrotomy closure, this is how it looks from the anterior side. From the posterior side, this is the posterior window which we used for reduction and putting the clamp. This is the head of the fibula, so you can get a orientation. This is the biceps and the lateral collateral ligament, which is absolutely intact. This is our peroneal nerve, and this is the soleus muscle, the lateral gastrocnemius and soleus. These are the 2 muscles which have been sutured back. This is our post-operative X-ray. The intercondylar seems to be not perfectly aligned. Over a period of 3 months, the patient underwent perfect recovery, the wound healed perfectly, and you can see that the fracture has also healed in anatomical position. Now, sometimes you may require a plate on the posterolateral side. So this case I am sharing with permission from Jignesh Bhai because it is his case. This is the place where the posterior cortex is a separate fragment. And just by reducing this condyle, we are not going to be able to support this posterior cortex, this marginal fracture of the posterior cortex. So here he has reduced, this is the articular portion, this is the marginal portion. So having reduced the articular portion and stabilized it with K-wire, this cortex he has supported with a small plate, and you can see the neurovascular bundle is so much near. So the plate has to be really small, really short. We cannot use long plate on this direction. Now another case, this is the last case where again you see a lateral condyle which is badly comminuted, a medial condyle which is good. The lateral condyle is showing multiple fragments. This is the CT scan. So you can see the central piece has caved in, and then there are 4 peripheral pieces which have blown out. You can also see a long split on the posterolateral aspect in the tibia, and this marginal piece which will have to be addressed from the posterior side only. There is no way we can address it by any suprafibular or anterolateral approach. This is another view of that same fragment, and this is the approach, the Frosch approach. So this is the posterolateral window. You can see this is the remaining of the soleus, and this is the screw, that one of the 3 interfragmentary screws that I have passed from behind, 2 screws holding that marginal fragment. I would have put a plate, but I did not want to because it was a bulky muscular patient and it was difficult to retract, and I was worried about the anteriotibial vessels. So I put 3 screws, 2 6.5 cc screws. They held it well. And then the support was given with the anterior raft plate. This is the post-op X-ray. You will be thinking that this screw is intra-articular, but as it is going along the slope of the tibia, it is actually absolute subchondral screw. You can see even in the lateral view. This is the patient's wound healing at the time of suture removal at 3 weeks, and this is the movement, and then patient went on for an uneventful recovery. So friends, to summarize the Frosch approach, I would use it for lateral condyle fragments fracture with coronal split fragments, or a posterolateral displaced condylar fragment which is not more than 5 centimeters, because beyond that I will not be able to expose by the posterolateral window. Badly comminuted lateral condyle fracture as a part of bicondylar fracture, you can use this approach to fix entire lateral condyle, and these marginal or rim fractures of the posterolateral condyle also, if you want to address along with the anterior part. So in short, whenever you feel that the lateral condyle requires a raft plate, but some posterolateral work, then you can use this Frosch approach. The technical tips: long incision is recommended so that you don't put a lot of strain or stretch on the retraction. Thick flaps, anterior and posterior. Superficial, peroneal nerve is quite superficial, so you should be gentle in putting your incision. The distal extent is limited by anterior tibial vessels. Watch out for it, don't damage them. Visualize the reduction by anterolateral arthrotomy. You don't visualize from behind, you visualize from the front. And resuture attachments of the soleus and meniscotibial ligament. Thank you very much. I open it up for questions.
Thank you, Pranav, for taking us through the various steps of Frosch approach. And I must acknowledge the photographs and the video was excellent. We could actually visualize, and that case we could not have done by any other approach. Kashyap, do you feel that this could have been done by a suprafibular approach?
See, there is a definite place for a Frosch approach, but largely, while I am extending my indications of suprafibular head, so many of these cases I can do it very well with suprafibular head. I can in fact put a rim plate which supports the posterior fragment also. But when there is a one case which was Jignesh Bhai's case, where there is a cortical as well as with the articular part, like that part, like volar Barton fracture type fracture of posterolateral area, that actually requires a posterolateral buttress. So along with that, if there is an anterolateral fracture, then those are the cases where Frosch is required. But Frosch is not a very easy to learn. There is a little bit of learning curve there, and you don't get as good exposure of both the windows as you get in individual. So, but there is a definite place to this approach.
Tanna sir, before this approach was described, I think all of senior teacher used to manage these fractures. So how was in those days? Was it by hooking with KYS or was it by, sir, you are muted. Sir, you are muted. Can you unmute yourself? Yeah.
From anteriorly, we would try to bite in a screw there and try to stabilize it. That was the maximum which we did it, and otherwise it was left alone. But it's interesting that just few days back when there was a TraumaCon where Paul Tornetta was talking, and he mentioned about it, that he never does this posterolateral approach. He does anteriorly, it is possible, he just stabilizes it, and this is all what it is, and he has never regretted. So I think in a sort of a small controversy, I would like to quote Paul Tornetta. I am not endorsing it, but I am only talking about it. This is exactly how we spoke. And all of us are so geared up, including me, to go to the posterior approach, put in a small plate and all. And when he came out, he obviously faced a few questions, but he just stayed, and with his stature and everything, he just carried the day. You don't need it. Don't do it.
And suppose if you don't address, you get a minor instability, posterior inferior instability, which will managed by our patient with the exercise and on. So they are carried on, but some deficiency is always there, sir.
I think, see, it is like the argument was, there is a definite conservative treatment for a minimally depressed lateral condyle. We all know it very well.
Yes, yes, right.
Yes. Same way, he says this is a conservative treatment for a posterolateral fragment. We don't need anything to be done. Now, this is his point of view. I think we just talk about it and proceed further. Because he
Dr. Dr. Sarvaiya wanted to share some experience.
Yes, sir. Dr. Pranav has shown the case where the fibular head was intact. So, technique has been devised where you osteotomize a part of the posterior fibular head. And then you get a proper exposure, because with this approach also I have done in a few cases, but it is very difficult to just get a view on that fracture when the fibular head comes in the way. If it is already fractured, you can just strip off that small piece. It's not a problem. But if the intact fibular head is there, going and putting a plate in that corner would be very difficult. So some parts, some 20-30% of the posterior fibular head, which overhangs on the posterior side, if you can osteotomize, you get a very beautiful exposure.
Jignesh, you ever did a osteotomy?
approach which has not been discussed, I think the same Dr. Tanna sir was speaking where Paul Tornetta described, there was a person from America, Tanna or something. He had shown a case where he does a partial osteotomy of the fibular head and then he reflects with the LCL and then he gets a whole exposure where you can put anterior rim plate, anterolateral plate. So that approach
needed when the lateral fragment is just behind the fibula. When it is just behind fibula, that means you will not be able to access it from the side of the fibula. Then you will have to do that fibular osteotomy. Otherwise, you don't have to do it all the time.
the neck region.
At times, there is already a fracture of the fibula, which you can really revert it and you can really retract it, go down, do the job, and then afterwards you fix up the fracture of the fibula. Is he there? Dr. Jignesh is there. I think we are all.
Jignesh?
Yes, sir.
Anytime you were not able, you explored and you were not able to put a plate, a small plate also?
No, sir, it is not happened like that. You can always do it.
We can always do it.
Yes, sir.
Our opinion there.
Sir, I will avoid definitely a fibular osteotomy by any means. The person who has devised this approach of transfibular osteotomy, Lucien B. Solomon, he is an Australian guy. I met him in an AO advanced course and I talked him personally with that. He said, I am also stopping this. He has also stopped the fibular osteotomy. There are 5 reasons for that. One is you are endangering the common peroneal nerve first. So it is you have to handle the nerve then you are likely to get a palsy. Second thing, you are removing the fibular head and refixation sometimes become difficult because of the comminution and fracture there. And so it will become laxity there. Third thing, you can create a posterolateral corner instability. Fourth thing is that by removing everything, you are making all the fragments avascular. And they will go for secondary absorption and collapse. So as far as possible, you can accept 1 or 2 millimeters cap or mal reduction rather than doing fibular osteotomy.
No, the fibular osteotomy means is only a part of the fibular head, not at the neck level. So the whole part almost remains vascular. It is just a small flip of the fibular head that you do and just to elevate with the LCL.
There are many variations to it.
Yeah, you can do, but I think regular Frosch approach without osteotomy and preserving ligaments will give enough access to reduce the fracture. If you do proper submeniscal arthrotomy anterolaterally and anteriorly, you can see whole articular surface from posterior and anterior and you can fix it nicely, very nicely. Yeah. And I have done 38 cases now and I think it is proper fixation. Most way, I could have built 2 plates every time.
According to
my only reservation
is the problem.
Yeah, Pranav, you wanted to say something? Pranav,
my only reservation of putting implant in the posterolateral area, 2. One is if at all it requires to be removed.
Easy. I have removed it.
So we have to send. So then in that case we all have to send to you. And second thing is that
like all of us, if we send cases to Jignesh, experience to
Second point you said.
Second thing is that the anterior tibial vessels, they are really in danger. In that area, they are really they're not so huge.
I'll be showing in my lecture. It is very close to it. Yes.
Very close, but see, you don't have to handle the vessel. You have to just put it under the vessel, and you are not going to put a longer plate. I can always put. You can always put one oblique screw below the vessel without endangering it.
So Jignesh bhai will be problem. Yeah, Jignesh bhai will be looking forward to a cadaveric course from your hand to have a proper dissection in that area.
Sir, it will be great pleasure. I definitely will do it.
Any member,
I can put in.
Yeah.
The fracture of the lateral side is going far too distally.
Yes.
Then what do you do with the artery? Is it possible to just go there, ligate it, and go ahead and do it? What happens?
Sir, ligating anterior artery will definitely jeopardize the blood supply to the anterolateral compartment. We can't go. Sir, posterolateral window is only for reduction of the posterior corner of articular surface.
Yes.
If there is a fracture, you manage that fracture by lateral plate.
Or even
or anteroposterior screw from the anteroposterior screws.
Yes.
But we cannot put a plate on there. Or what happens? Suppose, sir.
Jignesh,
yes,
we all agree to what you are saying. This is all what all of us are doing. My issue is when the fragment is going down.
Yes.
When the 2-hole plate is not enough.
Yes, sir.
Rarely this is required. And then when we go down, either we leave it, we don't fix it up at all, or we put in a screw or a cable iron and forget about it. Or go down distally.
Yeah.
Or go down distally. Ligate that artery. If we ligate that artery, what I am asking is, I am not recommending to ligate the artery, but I am not aware of what will happen.
Yeah.
Any idea? Is there any literature of saying that if you damage that artery, what will happen? I don't think there is any. To me, I have tried to find it out. I couldn't find any literature because it can damage and it can really produce a hemorrhage. That's the reason you have to be careful. But if you go down and ligate it, so that if you can put in the plate which is longer down, now what happens? Pranav, any idea?
No idea, no experience of doing
Yes,
like
sir.
that.
I agree completely with you. So that is what I'm saying. Let us pass on this message to our viewers that this posterolateral window is primarily to get a good reduction. And fixing a plate should not be your one and only goal in that area. You get a good reduction, and once you can hold that reduction even from the anterolateral plate or 1 or 2 screws, that's good enough.
Yeah. So the indication is
as
that
far as possible, you should try to put a plate if you can do it very nicely. It definitely gives a sure fixation shot to the posterolateral part. And see, all your wrapped glue cannot go that much posterior behind the fibula head to support that posterolateral fragment. If your posterolateral fragment is very big, extending anteriorly, then you can fix it with wrap plate. There are limitations of doing wrap plate fixation by posterolateral, fragment. Cannot be fixed by wrap plate. You have to put a posterior plate and buttress it.
So rough screw outside the plate can fix it?
Sir, the screw in metaphyseal bone, the screw outside the plate will become loose. It will not support gradually. Get where it will become loose. The best way is you put a small plate and get 2 screws posterior and anterior. It will be easy.
Yeah.
It's just a mindset that I don't want to put it.
Yeah. There is one question from a listener who is asking, what are the subset of these depressed fractures which get the worst stiffness in your experiences? Which are these knee patients who get profound stiffness? Is it posterolateral depression? Is it the central depression? Is it the peripheral rim depression? Which is the one which gets most stiffness is the question. Yeah, Kashyap?
No depression.
Tibial tuberosity avulsion.
Tibial tuberosity avulsion. Those cases give the maximum amount of stiffness is what you feel.
Yeah, so principally those which you are not mobilizing immediately post-op, and the tibial tuberosity avulsion injuries or the extensor mechanism injuries are those.
Where you tend to immobilize.
I have been showing these cases, those which have been conserved with a badly shattered upper tibia. The range of movement is not the issue.
Not the issue.
Range of movement is not the issue. The pain and the discomfort and walking and everything is the issue. So I feel the stiffness, as very rightly Pranav mentioned, if you are going to plaster it and leave it there, then it's going to have a stiff. If you really start mobilizing it early enough, whatever is your articular reduction, you are going to get the range of movement. So the range of movement, when we demonstrate that the patient got a good range of movement, I feel that is what is probably not the one which we are really looking for.
Okay.
What we are looking for is a long-term pain-free mobile joint.
Yes.
It is where the whole issue arises.
Jignesh bhai.
Moving on. Kashyap, I think you are at 18 Mbps.
Yeah.
Gadegone sir, you wanted to say something?
Yes. Anterior tibial artery, even thrombosis and injury can cause anterior compartment ischemia.
Yes, sir.
And probably it may lead to the necrosis or
your compartment.
Yes,
sir. Agreed.
Yes, sir, I agree.
We have to look on the third day whether there is because if you are retracting, though the artery is intact that time, it may be injured and traumatic thrombosis may occur. So therefore, there is a danger and it should be done by expert person, and it's not a cup of tea of average surgeon. So the message should go that you must learn that the technique is good, the approach is very good, but it should be learned first on the cadaver and then one must do it.
Yes, definitely there is a learning curve. And after comment from Vijay Kakatkar sir, then Kashyap, in the meantime, you please share your screen, Kashyap.
Yes.
And by the time Kakatkar sir, you can put your comments.
There is a new approach which is now called as a modified Frosch approach, wherein you go posteriorly, posterolaterally, and instead of going on the head of the fibula, you go posteriorly, and you don't have to dissect the lateral popliteal nerve. you can actually go medial to the nerve and you get better exposure, and you can even put a plate more comfortably than the Frosch approach.
Any personal experience
This
of
is a
that approach,
modified
sir?
Frosch. Yeah, I have done 2 cases and it definitely gives better approach.
That approach. Okay.
But again, the same thing, if there is an associated injury on the anterolateral side or anteromedial side, then changing the position becomes a problem.
Okay.
Yeah.
So
you
with
have
that
to
note,
do this in
yeah.
prone position, and then make the patient supine, and then go ahead with the remaining fixation.
Yeah. With that note, we go ahead with Kashyap's lecture.
Chandak sir, you please, close my video so that.
I'll do that.
Yeah. Is my presentation?
Yeah, we can see your presentation, but bandwidth still is a problem.
Yes, sir. I'll start if the things are not, then I try.
Yeah. Please proceed. We'll have a couple of slides. Go ahead.
Yes, sir. Yes, sir. So the Proximal Tibia is covered with meniscus, and the meniscus more joint reactive, because mobile it is small. In the upper end of the tibia is dome shaped, because when there is an impact, the impact is borne by lateral meniscus first and then by the tibial condyle. So in a side, whenever we see there is a comminuted fracture, there is all chances that lateral meniscus is injured. So this is dis versus dome concept, which is by Egli, where because of the medial tibial condyle, coronal of the of lateral condyle is the spoken Chandak.
Yeah, I think your voice is breaking.
This is from the anterior-lateral approach, which is an usual approach. But now the approach which we are going to discuss is about lateral. This is tibial condyle fracture, and there is a deep posterolateral comminution. These are the cases where you need to go and assess this area. So this approach actually devised Chang et al., Chinese surgeon, and there is a nice description of the approach seen in this paper they have described. And this is how steps are. You take knee, keep a bolster under the little gentle flexion, then take a curved approach over the girdle. This is how the initial exposure is. Then vertical of the leg is the little bit behind. Then you come approach over the leg. Then your and clearly you have to identify a fibular collateral ligament, which is from the of the fibular, and to see, because you can see that then you can reach deep posterior. For this is the once you do clip of lateral tibial plateau, you can all of the lateral tibial, and once you wash and you can exactly like a CT area you can reach with this approach. Your lateral give you to this area, and then this bone gouge which I use to take a bone graft from the medial tibial condyle, because medial in this case, and graft was under this lateral tibial condyle, and this is how and this is fixation done with the K wire, and then this is how the plate is. We can see stored lateral tibial condyle, and then submeniscal artery is closed. See the collateral ligament which is supposed to suppose this IT band and the anterolateral muscles of the leg, and then you close the sub. This is approach is done. There are some cases which I will be showing were done by this case, this approach. This is another osteoporotic posterolateral there. This is how the exposure we can see up dial. This exposure to there, and then it is elevated under and bone graft triocyte, and then how we can see the nice and elevated, and this is how these are the post-op X-rays of this patient. Then again a case with this approach, which is shown in Pranav Bhai's case. Really, this structure also, if you screw actually going dead to the posterior aspect, and then underneath there. So this is the use of the rim plate with this approach, and this where this was a complex bicondylar. There was a coronal split on the medial side, bad comminution on the posterolateral area. This is done using the same approach. Another case with lateral done with this approach. We lateral aspect. So from there also you can reach up to there. So the cases which doesn't require a posterior this approach. This is another case badly communicated by this was medial plate, lateral plate as well as this suprafibular.
Kashyap, voice is really breaking.
Sir, I'm really sorry, but I tried all the way, sir.
Yeah, no problem. Yeah. What I would suggest is, if you can post the video, we can attach it to the presentation. And
yes, sir, we will do that. I'll do that.
Though the images we could see, and a lot of good photographs we also could see, and the good exposure opted we could see, but the voice was almost voices interrupters. So
yeah, it's very posterolateral compression. Can 2 slides. Close my presentation.
Yeah, go ahead. We can see the X-ray. X-ray is being seen.
This is restored, and this is the bicondylar where the mid curvature was also, and that was also reduced under vision with the medial submeniscal arthrotomy. Lateral approach to lateral tibial plateau is an essential armamental in treating proximal tibial fractures. It can obviate need of going for posterolateral approach in some cases. Not because
okay.
Sir, should I continue with the posterolateral?
I think the voice is really breaking. Dr. Kakatkar, sir, you have some question for him?
Yes, probably showing the good slides and everything, but we are not getting the message because of the sound.
Yeah, that was a great difficulty.
Yes, I'll record the talk and I will attach it to on OrthoTV. Yes, sir.
Yeah, that would be better. That would be because the slides, as we could see a wonderful exposure to the lateral condyle.
Yes, sir, I'm really sorry because this is the 10th webinar. This is the first time I heard this issue. Actually.
No problem. This can happen. So nothing to feel sorry about it. So it's only the bandwidth.
Kashyap bhai, you also attach it to our WhatsApp group.
Yes, sir. Yes, sir.
Yeah.
Yes,
so Kakatkar, sir, you have wanted to ask some question. We can listen to him now. Yeah.
I think Kashyap, it's an excellent approach. I saw it in one of your last webinars also. And I had discussed with Dr. Chandak later on, and then I was highly impressed. I had never done by this approach. I am waiting for a case where I can use this approach and get that kind of an exposure. And I think that ream plate also is very beautiful. I have used it in a couple of cases in the past, but not in this particular approach. I'm quite impressed, and I think it's a real good addition to the approaches that we were already doing. I'm sure everyone should really get acquainted with this approach, and that can really sometimes avoid the posterolateral approach, which it technically is much more demanding, I think.
So I'll try and record all in a video by tonight, and I'll share it with Bidlani sir. Yes, sir.
Yeah.
Yeah, what I'm surprised is you heard him talking this about 3 months back. If there is 3 months में एक भी upper tibia like this, you didn't get it. In your high volume.
Right.
Sir, अभी COVID चालू है ना?
Okay.
I'm just trying to pull your leg. Don't worry.
So Kakatkar sir, all of us would be waiting for an opportunity to have this supramalleolar approach as well as posterolateral approach. I'll move on and finish up the last lecture, and then we'll have case from Tanna sir, and then we'll have a panel discussion. So I'll be speaking on methods of elevation and the articular reduction. The basic emphasis is on the elevation of the depressed fragments. And I feel the biggest pleasure in orthopedic theatre is restoring the articular congruity in a difficult, complex articular fracture. We have noticed various depressed articular fragment patterns, and they take these various patterns. In the central depression, I would find them into these 4 categories. Sort of a pit depression where it goes into a sort of a gadda appearance or a pit, or a collapsing roof where the whole roof of the lateral condyle collapses, or into a boat which appears like a sinking boat and a free floating either aligned or a topsy-turvy fragment. And then we'll have so this is a pit depression sort. This is a central complete depression. This is like a collapsing roof. The whole roof of this condyle has collapsed. The outer margin is intact. Then we may have a sort of a sinking boat appearance where this has collapsed and this part rises up into the joint. So it has lost its attachment here. Then a free floating fragment, which could be either topsy-turvy. Then there is a depressed fragment with splaying of metaphysis. This is a quite common variety. And in this type, many times the lateral meniscus may be found entrapped. At times we find this typical variety where there is a locked lateral condyle. If you try to do reduction, it doesn't come. We have to manipulate this fragment back into position by a dura elevator. And we may have a complete depressed fragment completely, or we may have complex depression. So these are the various patterns which we find. And these are the various images like a collapsing roof. So this you will find various patterns which keep on happening into the articular surfaces of this complex articular surface depressions. And many times we have a complex depression. So our aim is to get the articular surface back into position. And this one picture I like to emphasize quite often. So this is lateral tibial condyle. This is the hibernated part of the medial condyle. So how do we see on a lateral Siam image? So we see a lateral condyle and we see a medial condyle. So medial condyle is more proud, so we can judge which part we are managing. And if you put a dura elevator in the intercondylar eminence area, this is the intercondylar eminence area. And if we put this is on the lateral condyle, and if you reverse the dura elevator, it would be onto the medial condyle, the concave part. The tibial plateau view, when we get the articular reduction back, this image is really important as told by Tillman and Moore. So we get 90-degree view as well as 115-degree view. What difference does it make? So this is the view where it is 90-degree, and this is the view which is tilted view. So in this we get the real articular view, and you can find this sharp subcondylar bone. So pay attention to this image, and this is what. Here the depression appears only 6 mm as per his paper, and here, and which I also found true, here it appears 12 mm. So judge your depressions in these two views. Study of depressed fragment is important for realignment, and this scanning helps tremendously. All these scanning images, we should look at them. The key to management of this depressed fragment is have a proper assessment, take a traction view. So when we take on a C-arm, we take a traction X-ray on AP and lateral, then we apply distractor force, elevate the depression, and then with fixation of those fragments in situ with raft screws or whatever means, and then buttress and graft, or at times graft substitutes, or even without graft, depending on the situation. So imagine various punches required for various fractures. So this appeared quite innocuous on a routine X-ray, but the imaging really gave the various types of pattern of fragment depressions here, what we need to elevate and what we need to buttress. So these are the various things which should be available in our armamentarium, and I like to emphasize on various angles of these punches, small and large punch. There are various indications where to use them, and then we keep it elevated and then lock them into position. So imagine the punch for this. So here you need you can't elevate this from the lateral side, you will have to go medially. This needs a elevation punch from more posteriorly placed window. So you cannot elevate it by this window. So we need to imagine our punches appropriately. This is the fracture where elevation of sort of roof collapse of this complete condyle would be elevated very nicely, and your punching force has to be here. This requires imaginative elevation because here the fragment is a very small fragment. So either if you directly look into the joint or you compress the joint, then get back fragment into position. Many times elevating with a punch and disc of bone is quite useful, especially with multi-fragmented depressed fragments. So this is the window which I would like to plan on the medial surface for elevation of the lateral articular depression, and then the punch is inserted of various angle. This is where we would make a window. The window and the punch takes along with it some amount of articular bone, or we can take out the bone also. So this is the window which would make. And imagine the punch for this. Here you will have to put your punch and a large punch from this side so that it comes to the position. Many times if we have difficulty, this exercise in theater makes it really very important. So you can find out how the punch goes and various patterns and the various positions of punch. If you do this exercise, we can exactly know which is the posterior border, which is the anterior border, according to the densities, and we can put our eye focused onto these images. Now, this requires a punch from the lateral aspect. You can't elevate it from a medial inserted punch. So this fragment would go up with the lateral inserted punch, as you can see here. So here I would introduce a K-wire, and with the K-wire, I would joystick it into back position. The exact area to be punched is given by this section so that we can exactly elevate the depressed fragment. This one, a whole condylar roof collapse sort of picture, is the easiest to elevate, and I usually would advise a cine effect. So look at this image. If you can have this cine image on C-arm, and this can be done by setting the C-arm to 16 frames per second setting, where we can get this cine effect. So exactly we get how much amount of elevation needs to be done. This is completely restored, and then the void can be reduced by compressing the fragment by whatever means, and then fixing it appropriately. That would give an optimum articular subchondral surface and reduction. This is a sort of a sinking board. Here, if you just punch, it tries to jump up into the joint. So we lock it with the K-wire and then elevate with a punch appropriately. With multiple fragments, it is easier. So here you will have to judge by the densities. In these situations, many times the submeniscal arthrotomy is the best. If there are multiple fragments, then we can align it better. When we use a punch to reduce the width, condylar width, which is increased, what happens? This tries to bury in this soft lateral condyle. The medial usually is tough. So for that, either you use a collinear clamp or we use a plate clamp or a washer assisted clamp so that it can put pressure onto the condyle to reduce the width. This is a lateral fine tuning for small fragment elevation. So if this is found depressed, we can find it out in a good C-arm picture. Then you lock it into position once it is elevated, and the elevation sequence, if you take into a cine effect, then it exactly gives, now it has come appropriately and you are exactly below it, and then you lock it with a K-wire in that position. When fixing, this would require a raft position of screw just beneath this. Then only this would not settle down in the subsequent healing process. And then this also I found quite interesting in a depressed lateral condyle. when we elevate and fix with a plate, if plate is bit completely nicely positioned, that would provide a good sustentaculum effect. And a screw from the opposite side, if it is supporting that elevation, that also helps quite commonly. As you can see in this picture, here, this depressed fragment, when it was locked from the lateral screw, did not remain affected. So this is my own case. Here I found a depression, though intraoperatively it was fine. And then changing the screw direction from medial to lateral. So this keeps it elevating further. So this I found quite interesting. I would like opinion on this also. So this is one difficult depression where multiple fragments are there and the whole thing has caved in, not as one fragment. Then we can have a meniscus lifting approach, use a meniscal lifting approach, tie the meniscus with a couple of sutures. So these are the fragments. There are multiple. This has gone inside. So you have to exactly look into the joint and then elevate. And this you can see from the lateral side. Have a small distractor across the joint, pull the leg, and then you can put it back into position. With raft screws and plate, you can really elevate and fix that very nicely. This typical fracture, if you pull it, it doesn't reduce well into position. So dura elevator, small arthrotomy, and getting that flip back into the joint helps. This is an interesting topsy-turvy fragment. This is completely, the articular surface is down, as you can see from here. So this would require opening the joint and then turning the fragment and then fixing it appropriately. Understanding the depression. So here it looks subtle, though you can make out that this is the density. So this we must not miss on a C-arm, and the effect of cine loop, as you can see, I'll just rotate it fast. So you can appreciate the depression, what is being elevated. So get this effect. Once you get this effect, and you can see now the fragment is elevated nicely, and after the fixation, that gets an absolute perfect restoration of the articular surface. Here, our wrapped screw should support that depressed fragment. At times, you have to place your plate accordingly a bit more posteriorly so that the anterior end goes more anteriorly. Holding the reduction is another important thing. So in this depression, so here 2.5 mm K wire or 3 mm K wire, 3 K wire in a row, getting it up elevated and then fixing, avoiding the intersusception. This intersusception always leads to varus. So this has to be avoided. So getting it back, elevating with punch, holding, reducing the condylar width, putting the fragment back into position, holding with the subcondylar K wires, multiple of them, so that the reduction is held well. Condylar width is now compressed. I like to use this clamp, a specially made clamp, which either with a washer in the collinear or with bullet points, or this clamp I like to use quite often. So it has a plate attached itself to the clamp itself. So this part doesn't bury into the joint. And I also like to use this ohm clamp devised by my OT assistant, which holds the clamp, the condyles into position nicely. This is how the plate clamp. So you can attach a small 1.5 K wire, compress. So this gets the condylar width back into position without fragmenting the fragments. Pay attention to the raft plate which you would like to use. So somewhat more posterior if it goes, then this part goes more anterior. If it is putting a bit more anterior, this part goes horizontally. A well molded plate really gives a good effect in holding these fragments. So how I begin a case in short, aspirate the knee. If it is quite tense, I like to aspirate by 16 gauge needle. So whenever there is a hematoma, that gets out. Otherwise the field gets all bloody with the hematoma which is pouring out. 5 incision technique. So this is usually the 5 incision window, a medial MIPO, a lateral in a bicondylar fracture, and a small fragment for elevation of the punch, and laterally and medially again a MIPO incision. So these are the 5 incisions usually needed for bicondylar depressed fragments. Subcutaneous tunnels are made, clamps holding the reduction, articular plateau going back into position, varus is reduced, and then fixing the raft plate. So this is intraoperatively when we hold, so we reduce, hold into position, and then fix appropriately. This, when articular surface is shattered, multiple subchondral screw hold really gives a good holding of to the articular surface. So this is the sequence of application of screws. in a bicondylar fracture. At the end, once the fixation is achieved, you test the full range of movement. Friends, our patient usually desire good range of motion, pain-free, good function, and even after removal of all metal, our bones should be surviving the whole insult of injury as well as the surgical exposure. That what would make a tibial condyle result really good. And the patients are then happy with a full range of movement. In nutshell, improve your armamentarium, reduce the operating time, possibly use 2 drills and multiple chucks, use essentially a collet to hold K-wire so that you can rapidly put those things into position, elevate the plateau, which really elevates the mood of the whole theater. Thank you very much. Any suggestions, any points you can make, I would be ready to answer. Kashyap, you are muted.
Almost you have covered the effect of reduction. Sir, I have requested Jignesh Bhai has a posterolateral approach presentation ready. If you wish, because mine is not working, it's a very short presentation. Jignesh Bhai will give you that because that completes the 360-degree of problem.
Yeah, Jignesh Bhai, go ahead. Please share your screen and complete the thing.
Can you see it?
Yeah, we can see it. Just go on the presentation mode.
When we see posterolateral condyle tibia, we have to do something different to change the outcome, because these are the subset of the fracture. I will show cases that cannot be definitely done by anterolateral approach or any other approach. We have to go posterior and do it to justify our fixation and treatment. So this is approach. This is a prone position, then this is the outcome. So we have to do something different. This is most important slide, I say. This is applied anatomy to be understood. It gives 5 to 7 centimeters of the window to work over here. But most of the fracture are in such a pattern that you don't need more than 7 centimeters. The limiting factor is anterior tibial artery. Lateral genicular artery can be cauterized, and common peroneal nerve. So we are working in this. You can follow my cursor. This arrow. This artery is anterior tibial artery, and this is this thing. But we get enough place. I will show video also. That enough place to work on it. So this is a 21-year-old female and got vehicular accident, and she had a classic posterolateral split depression fracture. We will see in the CT scan. You can see very large chunk, but there is no fracture anteriorly or anterolaterally. And this articular surface facing posteriorly, and you can see there is a posterior cortical split, big piece is there with articular surface. So this is how the fracture looks like. We will see now approach. Left side is thigh, right side is calf, and incision is directly posterior to the fibula head in prone position, and cross the puppeteal crease by 1 to 1.5 centimeter more, and make a little bit proximally big incision so you can identify the nerve properly. Most important part is identifying the nerve. In a thin patient, don't make a very deep incision. You will cut the nerve immediately. It is very near than one believes. So cut gently skin and subcutaneous tissue. Don't cut the fascia and identify the nerve underneath the fascia before incising it. So, and dissect the fascia from distal to proximal. Just cut distally and run your finger, and you can easily separate the nerve. But just isolate and identify the nerve, but don't separate it in a rubber tag. We have to just see the nerve. It doesn't come in the approach. It remains 1 kilometer away from the working area, I say. Don't retract the nerve. You are going to work quite medially, medial to fibula head. So it just need to be identified, and it is not. So it doesn't come in the working field. So it is in the approach and not in the field. So this is how we identify the nerve, and you identify lateral head of gastrocnemius, which will be retracted laterally. This is the nerve, and this is the soleus muscle. Once you retract the lateral head of gastrocnemius, you can see soleus muscle in the floor over the fibula head. Then we remove the soleus muscle with the knife sharply from the fibula head and make the fibula head totally white. Because subperiosteal elevation don't enter in the substance of the muscle, because you will not be able to identify anterior artery then. So if you subperiosteally elevate from the fibula head, a soleus muscle, you can easily identify anterior tibial artery about 1 inch distal to tip of the head of the fibula. So when you dissect medially over the head of fibula, be careful. The moment you remove the soleus muscle from head and retract it medially, you can see the fracture site. So this is the area, 3D CT combination. This is the split, and that is a depressed articular surface you can see in the field. And that's the articular surface. So this is the arrow which is matching this articular surface depression with the 3D picture where we are. Now we'll start elevating it. So there is enough space to work on. So elevate the condyle with good amount of subchondral bone till you don't see the condyle maximum. Give some traction so you can elevate it properly, and put 2K wires from the side, because all the vessel and nerve is behind. So you can put safely wires going under the elevated fragment, and you can see the wires inside from the window, that wire are exactly supporting the fragment subchondraly. And you can confirm your elevation under IIT. So this is elevated fragment, and you can see the IIT, and you can see in lateral view my wire is quite posterior, just supporting the fragment. Now we use a feeler. I use a Kronos every time. Feel and then cross the window and put a plate. So you can put 2-hole plate, 3.5 mm distal radius easily by putting all 3 screws proximally, 2 screws distally. And this is how we fix it. And this is the post-op picture in the IITV. And this is the closure of the wound. And that's the post-op follow-up X-ray, 4 months. And they say full movement with good stable knee. So we see another case. This is a video case. This gentleman had a fracture before 4 years of upper and upper foot tibia. And he was operated with the plating, and all implants are removed. And he again made an accident. And this time he got a posterolateral condyle fracture. And you can see in the CT scan, there is a depressed condyle. There is no fracture anterolaterally or laterally. Lateral rim was intact. So all the commuter fragments are only posterior part. So this is how the 3D CT picture. And this was a comminution in the extending little bit down also. And this is the approach. This is the video. This is the nerve surface marking. That's the fibula head. I am drawing the incision behind the fibula head. I am expecting now here, and horizontal line is a popliteal crease. I will go 1.5 centimeter proximal to popliteal crease, like this. Now incision, cut skin and subcutaneous tissue gently. There is a vein, so I lifted up the knife. I will cauterize it and then cut. I identified the nerve in the fascia. Now I will cut from distal to proximal fascia, and I will cut the fascia gently over the nerve part. Yeah, it's there, and I will just run my finger. It will separate the nerve. The nerve is separated. I will cut the fascia along the nerve path, so I can little bit mobilize it if needed. This is the soleus muscle, elevated. Now retracted soleus muscle. Now we see. Now I have identified the soleus muscle on the floor, fibula head. That's the fibula head. Now I am cutting the soleus muscle from the fibula head. Sharp dissection. No blunt dissection here. Don't use any periosteum or anything. Cut with the knife. You identify the fiber and go on cutting on the bone. You can retract the nerve little bit with the forceps. It doesn't cause much of the problem. Usually you don't get palsy. Go on cutting it till you enter the medial surface of the head of the fibula, and then you will be able to see the artery. I will show you. Keep your hand very steady when you use the knife, because nerve is nearby. You can cut the nerve. The moment you cut it, you can see the hematoma is coming out. This is the hematoma is coming out. This is the artery. My artery forceps is underneath the anterior tibia artery. But you have to just pass a periosteum underneath the artery to create a space for the plate, and you don't have to handle the artery. Then just there is enough space for mobilizing that. It is fixed. You cannot mobilize it. So it has fixed length. Now my suction is in the joint. It is a reverse picture. See, and that is a white articular surface is seen. It is depressed. I have elevated the fragment, put a K wire, you can see from lateral side. Now I will put a filler by putting a gouge. It is a very nice idea to do a broad gouge and slide your filler through the gouge in the defect directly. It will take about 20 seconds. Yeah, then you can push the things inside. Once it is filled, then plating is done. This time I have used the lateral wrap plate. Pushed this plate can match there. So I used that because it was a big chunk and a big area. So I used more commission. I used this wrap plate. I wanted to get 4 screws underneath the fragments. So I used that. But otherwise, most of the time I use T plate, distal radius, and that's the post-op X-ray. I had to leave the last 2 holes because I cannot go beyond that. So this is the limitation of anterior artery, and this is the post-op X-ray. So now there is a new plate is also devised, not entered in India, for posterolateral condyle anatomical plate. See, and I have compared this lateral wrap plate and the bone model. So lateral wrap plate needs little bit more curvature to band it to match the contour of the posterolateral condyle. And this new plate which is there, it is very nicely contoured. So that is the limitation of the wrap plate, which can be sometimes used on the posterolateral surface also. Opposite side wrap plate. Now we'll see few cases very quickly. Exactly how it has been done. It will be a little bit revision also of the approach. This is a X-ray and that's the CT scan showing the depressed posterolateral condyle. There is no fracture anterolaterally or a lateral wall, and you can see it is a considerable depression, about 8 to 10 millimeter depression is there. So it needs elevation and fixation. There is always a posterior split of posterior cortex. So it is all posterolateral split depression, prone position, skin subcut cut. Identify the nerve. Nerve is isolated by dissecting distal to proximal fascia. Now this lateral gastrocnemius, it is retracted. Soleus is seen in the floor. Soleus is elevated. Soleus is elevated from the fibula head. And you can see lateral meniscus can be elevated by taking sutures in it. You can retract the lateral head of the, popliteus tendon also, which sometimes comes in the way. It can be retracted medially. And you can see articular surface very nicely. This is a depressed articular surface. There is enough space you can see again. And elevated, you can see the bone substitutes which are there after filling up the defect and put a plate. This whole plate can be seen. So this plate can be put like this. And this is the post-op X-ray, and this at 3 months follow-up, there is good range of movement. He has got full range of movement and follow-up. So it is a direct approach which is better for treatment of posterolateral tibial fractures. It allows better fracture reduction, better stabilization, and better functional outcome. Another case, again there is a posterolateral condyle, 2 pieces are there. There is a split, and there is no lateral anterolateral condyle fracture. So again there is a marking. Now fibula head and popliteal crease, and that is the incision behind the fibula head. Common panel located, lateral gastrocnemius is retracted and dissected. You can see the anterior artery again going in the interosseous space between the tibia and fibula proximally, and that's elevated condyle with the K-wire in place. And that's the, you can see post-op and pre-op X-ray comparison, the perfect elevation and fixation with the small T plate. Another case, there's a very high fracture. It was just subchondral crushing and compression of the condyle posteriorly. So we went posteriorly, elevated, and put up a little bit higher plate. See, the screws are very much subchondral, but can be done like this. And when you suture back, suture the fascia to nerve only, then don't suture the nerve beyond that nerve. Otherwise, it can just entrap the nerve in the sutures. So leave that part of the nerve which is there. Proximal and distally you suture the fascia. So this is a post-op X-rays. So it's a road which is less traveled. But I say if you hang around, you can reach to destination perfectly well. So this is a very nice approach for a particular set of fractures, and it gives perfect window to work in it if you know the anatomy very well. Thank you very much, sir.
Thank you, Jignesh bhai. It appears we have done 3 or 4 cases right now itself. That feeling we got. So thank you so much for taking us through nice pictures. And I must appreciate the quality of your video. What did you do to get such a good quality video coming up in the webinar? Very nice video.
Sir, I record everything with my iPhone video.
With the iPhone video. That was good actually. We could see everything, every structure very clearly. Any comments, Tanna sir, for this presentation?
Oh, I think it's very good.
So, in this patient, there is no lateral raft pad, Jignesh bhai. There is only posterior pad.
Sir, there are no lateral cortex fracture or there is no anterolateral cortex fracture. It was pure posterolateral condyle fractures. Pure posterolateral condyle. There is no other injury in the knee.
Okay, absolutely. So, Pranav, your opinions on this?
This re-emphasizes what I had said. That from approach, if there is a lateral condyle fracture which requires raft plate, and posterolateral approach if there is a posterolateral condyle without a raft plate.
Right, absolutely. That was wonderful presentation. Tanna sir, can we have your case? Yeah, we have enough time, sir. Absolutely no problem. We can have your case. We will love to have that case. By that time, any question we can take up by this time, sir shares screen.
This posterolateral approach, I have 2 or 3 points to be added.
Yeah.
The number one is, is a wonderful dissection and everything, but as lateral gastrocnemius head you are supposed to retract. You can do little bit of facial cutting of the lateral gastrocnemius head so that that retraction becomes easy. And we almost always need to see the lateral geniculate artery that comes in the way. That is that is directly arising from the popliteal artery. So we need to identify it, cut it, ligate it, and then cut it.
So, sir, so this surgery should be done without tourniquet. Huh?
No, we always do it with tourniquet.
Tourniquet, sir. With tourniquet only.
Always.
But release the tourniquet before closure every time. Every time you do posterior approach, you release the tourniquet before closure. Confirm that there are no bleeders. And most of the time, what happens? This lateral genicular artery, the fracture displacement is such, it gets ruptured, and sometimes you get it in less displaced fracture. But when the cortex is displaced posteriorly, the artery is not there. I always, every time I try to find out, but in my recording I could not find out. When I not recorded, it is there.
Okay.
No, but slide which you gave, Jignesh bhai, that you said the most important slide, applied anatomy. If you remember,
that slide, is there. It is there.
That slide, I passed on before some 4 years, and there is a actually lateral genicular artery which is actually dissected in the wound. So to me, if I do 10 cases about, then it is seen in 7 to 8 cases. So almost always, you should go and search it. That's what I said. And the
doesn't bleed when you release the tourniquet.
Okay.
Even if
so
you don't
that's
mind.
a test. That's a test.
That's the test.
Yeah. Dr. Sarvaiya. Yeah, Dr. Sarvaiya
sir.
wants to comment. Yeah.
Just one question. You identify the popliteus tendon.
Yeah.
And then just underneath the popliteus tendon, you try to put your spike. So is it what you do on the medial side? The same thing is on the lateral side, because if you
it is very fixed structure and it is very difficult to mobilize the popliteus tendon.
Because if you use a tourniquet, you use a tourniquet, right? So your vessel actually will have less chances of getting ruptured. So if you just can identify the popliteus tendon and you put your spike underneath the popliteus, and with that you elevate to the medial side, your vessel is safe.
No. It's not possible.
It is not possible.
Not possible.
You have
one
not
thing
like the medial side.
What I do is, I say some, say Ryle's tube or some in-paint feeding tube underneath the tendon, and then I mobilize it up and down to put it. I never cut it because it's a very strong posterolateral support.
We don't cut it. We don't cut it, but where it is inserted on the back side of the tibia, on the posterior tibia,
it is inserted on the posteromedial side. On a lateral side.
Yeah, from posteromedial it fans out, and then as a tendon it goes to the lateral side.
Yes.
But you see the margin, the superior margin or the inferior margin, and just with a periosteal elevator, if you can have some space, and if that popliteus is a little bit elevated, then your vessel is safe. Just for the beginners.
No.
The vessel course is It is different as we could see from
It's
the
a
image.
different.
Yeah.
Yes.
Sir, populus tendon is at the level of joint line or a little bit higher up. And
and it attaches to the lateral femoral condyle. There.
Yes, sir.
No,
So it doesn't come in the way of your
Medial
fixation.
side, what you do? Medial
It doesn't
side,
come
you
in the
just
way of your fixation. Tendon
medial
is a little bit higher up. So it does. It is at a joint line. So you are elevating a depressed joint line. So it doesn't come in your way of fixation. Your plate and everything. It doesn't require mobilization. By and large, if you want to see this thing reduction, then okay.
Because on medial side, the populus tendon, once you are on the popliteus muscle, you just elevate it and then you are safe. So the vessel and
But you
everything.
are working under
But sir,
neurovascular.
vessels are
working
in center and medial side. In posterior condyle, vessel is not a problem. Anterior artery is a problem.
Okay.
Yes.
Popliteal artery is not a problem there.
But we can feel it is very, very in proximity. We can always feel it when you do it.
Yeah.
So after this complex approaches, now we'll have a case discussion. Tanna sir, can we have your case, please? Yeah. So that we end up on a lighter note after this complex.
I think some of you might have seen this.
Sir, we also have a summary from Dr. Gadegone.
Yeah, definitely we'll be having that. So he'll be scaring us not to have over.
हमको डराने वाला है और मैं बंद करने वाला है ऑपरेशन करना.
नहीं, मैं डराना नहीं चाहता हूँ. This is you are a master. You are a master, and I think everybody should learn your technique.
Yes. Tanna sir is sharing his screen. By the time we'll have his case.
और सब सुनने लायक गुरुजी से ही है.
Yeah, we can see you.
Now this is unfortunately I do not have a CT scan which was done, but you can see here, this is the tibia which is depressed on the lateral condyle.
Right.
And there is a fracture of the fibula which is also there. Now here it is, you can see this is the fracture of the fibula. And you can see the tibial condyle which was depressed here. But now once I come around, this is what I went. You can see this is the pre-op X-ray. You can see this depression here. Is it seen properly?
Right, we can see.
It is in the X-ray. This is the depression. Now this was a young girl. And basically I was operating for the fibula. The whole tip of the fibula was avulsed up. So it was out, it was above. And that is the reason I was operating upon. And basically, if I can just show you the video. No, it's not a video. Then the whole thing was unstable. So I went ahead and I fixed up the fibula. The whole knee was unstable because the fibula tip was gone. So everything was gone. And then I went down and elevated this piece. If you can see, this was elevated, this piece. And then this is after the elevation. You can see the articular surface has been re-established. This is the X-ray after the elevation. Now the issue is whether this needs elevation or it doesn't need any elevation. Probably if there was no fibula which was going to be done, then I may not have done the elevation. You can see this is the tibia, this is the fibula.
Right.
So now here it is. This is what has been the post-operative picture. This is the post-op picture. There is a small piece which is here, which is lying posteriorly, and this is the whole fibula which was being done. So I felt whether this was really worth doing it or no. It's a different thing, but being a young girl of 19, and this was already having the fracture of the fibula which needed to be done for the whole thing, both biceps and the lateral collateral, and everything had avulsed out. So it is the one which had to be done. So it was done. That is how when that was done, as you can see here, I had done the tension band of the fibula, which is done with wires, and it was sutured back completely. The whole thing was done, and that's the reason I went ahead and did it. And obviously the pre-op X-ray and the post-op X-ray, you can appreciate this is a small piece which is pressed. Whether single fracture like this, whether anybody would have tried to elevate in a younger.
So otherwise also patient is taken up for fibular fixation and the posterolateral corner. So always beneficial to elevate whatever articular depression is there, would be my opinion, sir.
No, my question is the other thing. If there was no fibular fracture, would you have done this elevation? Would we have done this elevation?
Oh.
If it was depressed tibia. Yes?
Most likely that would have been managed conservatively if there was no fibular fracture.
Yeah, I would think so. It would be managed conservatively.
Yeah, most
and
likely.
Whether this operation is going to add up anything to the patient or no, it also debated. Since there was a young girl and I was going from and I was in that
Yeah. So in the fibula, sir, did you use a sort of U clip or a TBW?
No, these are 2K wires.
These are only 2K wire. But then that fragment flips and avulses with the forces of biceps. So
whole biceps was away. First X-ray showed the fibula. Fibula was somewhere here.
Right. So that has been brought back into position. And
there is video which I thought I have downloaded it. And there is the whole knee joint is very, very unstable.
Right.
Yes, Bolo.
Yes, sir. To my mind, this is a posterolateral corner injury, which is a more of a ligamentous injury with the tip of fibular avulsion, rather than having, proximal bicondylar type of condition. This medial tibial condyle probably would have been left alone and no issue regarding that. But the posterolateral corner which you have fixed is very much important, because this type of injury occurs with a varus and hyperextension injury, where the posterolateral everything is gone and that has to be repaired. Otherwise, patient would have a posterolateral instability in the future.
Kashyap, there was no issue of fixing up the posterolateral because the fibula was so far away.
Yes, sir.
Definitely the lateral posterolateral was not involved. And
yes, sir.
Under anesthesia, the whole knee was very unstable.
Yes,
I have the video. If I can find it, I may give you. But at
yes,
the moment, I thought I have downloaded it anyway. So that was not the issue.
Otherwise, this could have been left misconserved.
Thank you very much for sharing this good case. Now, question to faculty: if there is a anterior cruciate ligament avulsion or PCL avulsion along with condylar fracture, do you get it attached by? What are the means you get it attached back into the position? Kashyap, how do you manage those avulsions along with condylar?
See, in a bicondylar and specifically in a medial tibial condyle fracture, which is described in very also, there is a quite associated anterior cruciate type anterior spine avulsion. See, there are two types of fracture of tibial spine. One which is wedged between lateral tibial condyle. That doesn't fixation, but the one lifted off. You can see a small piece which is anteriorly. Those are, and specifically in a young patient, I would always fix it. I do arthroscopy, but for these cases of bicondylar, arthroscopy is not practical. So what I do is I take a very small incision just from the lower pole of the patella to upper tibia, go medial parapatellar, excise a fat pad from there, and you can see nicely visualized there. So then you take a suture around with the arthroscopy, these loops with that, and take a pull through. So that's at some 10-15 minute addition to the procedure. But when you see in a lateral view, the small fragment which is lifted off and young patient, then I definitely fix it.
Okay.
And if the Kashyap, if the substance is avulsed from the tibial spine, then what do you do?
So if substance is avulsed, most of the time we cannot diagnose it. I have not seen quite often a cases where there is a postoperative epilepsy in a follow-up, because I tend to follow them up for 6 to 9 months very regularly. I record their clinical findings and everything, but I have not seen much cases. Hardly, I don't remember even any cases where I have seen an enteroposterior laxity after a complex bicondylar fractures.
Okay. Pranav, how do you manage these avulsions? Any tips from your side?
There was one case that I had shown where the intercondylar eminence was fixed with a screw. So for me, if it is a more than 1 centimeter fragment, then I would want to put a screw. Nowadays, we have got this very good headless compression screws of all sizes available with Indian companies. So that gives us a very good method of fixing these. Otherwise, if it is a comminuted fracture, then as Kashyap bhai said, I have my arthroscopist with me in the OT and he will do the pull-out suture.
Yeah, thank you so much. Kakatkar sir, Kakatkar sir,
Yeah. If the fragment is big enough and it is lifted up, I would definitely go for open reduction. After fixing up the condyles, you do a medial orthotomy, parapatellar orthotomy, and then locate that piece, put it back into its position. And the only precaution you have to take when you are putting drill is instead of using a drill, I always make it a point to use a K-wire of 2.5
ACL guide.
Yes,
ACL guide.
Because many a times, the drill, if it hits onto the screw somewhere, the drill bit is likely to break. So you can take a 2.5 millimeter K-wire and then you know the passage which is safe for you to fix the screw. After taking out that K-wire, you put a small 1 millimeter K-wire and put a cannulated screw of your choice, either steel or titanium, and fix it.
Yeah.
And I think you can get an excellent fixation in all these cases. In spite of having a ACL avulsion fracture, we can mobilize them if you have a bicortical hold for the thing, and you can mobilize them very quickly.
Yeah, thank you so much. I think Tanna sir is ready with his video. Sir, you wanted to?
I can't find it.
Okay, thank you, sir.
Sir is actually buying a house in Lonavala.
Yeah.
Sir, we can use a ACL guide for fixing these tibial spine fractures. I generally do a lateral arthrotomy, lateral parapatellar arthrotomy, and there you just can see the piece. And once you just put it into place into the crater, then you put a ACL zig on the medial side. So from anteromedial, you go to the lateral side, and through the zig you put K wires, and through K wires, if that the drill with drill, if you have a tunnel, you can put some sutures, and with a pull-out suture you can bring back through the medial side, and then you can, over a button, you can just pull it. So you can do open repair of the tibial spine also, but you should have a SCL zig with you so that you go exactly into the center of the tibial spine.
Okay, thank you so much. Gadegone sir, can you share your screen?
Yes, this is all summary. Everything has been said. So I will just summarize the whole thing. Chandak sir.
Daranamat sir.
No, Darana.
Yeah, please share.
So thank you all faculties for wonderful presentation, and our Guruji Tanna sir, he is always with us with learning process. Kakatkar sir, Chandak sir, Jignesh Pandya ji, Sanjay ji, Kashyap ji, and Pranav. Very excellent 360-degree exposition of the subject. So you know all this soft tissue is the most important thing, bone destruction and cartilage damage. And soft tissue complication rate is more than 50%. Hence, decision making is very, very crucial, because complications and prognosis are directly related to the degree of soft tissue injury and articular reconstruction. So decision making number, be aware of this type of presentation. Priority should be given to the soft tissue. Better to wait for surgery till wrinkle signs. Decision making, timing of surgery, image are planned. Only immediate indication is open joint, compartmental syndrome, and arterial occlusion. Rest of the cases, it should be a stage protocol. Decision making, third is a compromised soft tissue, temporary fixation by X-piece, or you can have a Steinman pin traction or a just cast, allow elevation and allow soft tissue to recover. Extent of damage is often greater than depicted in X-ray in upper tibial fracture. Hence, CT is mandatory before you plan. Decision making 4, radiological evaluation is must. Understanding fracture pattern, preoperative planning, reduction keys, and posteromedial and posterolateral fragments. Decision making 5, classification, AO classification and Schatzer classification at our service. But most important now is the 3 and 4 column complicate articular involvement, and that is the new thing which is added in the arena of the planning of the treatment. Decision which approach, anterolateral, posteromedial, anterior midline, posterolateral approach, we have to choose between all, depends on it is a morphology of the fracture. And prone, Lobenhofer combined approach as is described by the Jignesh Sarvaiya as well as other speakers. This is one of the new tool in the arena of our fracture management of upper condyle fracture. This is the complex fracture, needs stage protocol, medial lateral exposure, articular, condylar, interfragmentary, buttress placed and avoid a varus. So decision making when there is a bicondylar fracture, which to fix first, it's a temporary fixation first, then medial, and then lateral. Decision making in the lateral fixation, it is most important to elevate the subchondral part by a submeniscal arthrotomy. That is the most important. Unless you do that, it is not possible to visualize the articular surface. This is the case 1. It looks very small fracture, but you can see with the CT scan, everything has changed. It's a comminuted fracture, not only a split depressed fracture, but already the root has gone inside the bone. So this needs a double plating, though it was looking a very simple fracture. So morphology of the fracture, this is now innocuous fracture, as if there is no displacement, and you can see on CT scan there is a depression. Mostly it is in the center and anteriorly. So it needs elevation, and you can see a posterior tibial, there is a depression in the coronal fracture. So CT scan is mandatory. Posterolateral approach, one must know, because this is one of the arena, and fibular osteotomy without, we must learn. This is the posterior, it is already been told. These are all X-rays which I have done it, and with a similar kind of injuries. So if you are doubtful about the result of fixation, illegal or external fixate is the usual alternative for treatment of the proximal tibial fracture. So you must also learn sometime that it also helps in the management of this fracture. And stage treatment of tibial fracture is better than infected one. A malunited tibial plateau fracture is easier to manage than the stiff knee. And all most important thing is this, it's a complex injury. Himself invited trouble by accepting treating the patient. If you are not knowing exactly how to manage it, and don't repent it in future that I have not done a proper surgery or produce complication. A simple one example, a 26-year mole after motor vehicle accident with a compromised soft tissue punctured wound at the scene of the tibia and gross swelling. Immediate reduction and fixation by plate is a very attractive option without realizing that there is a internal glowing. And this was fixed by locking plate on the day of admission, reasonably good fixation, but you can see after a wound adhesion and infection, not relieved by antibiotic and dressing. These are the common things which you see in our practice. Consulted a next surgeon after 3 weeks, and patient 6 second opinion how to treat this patient, because if you invite a trouble and take the patient after knowing that we are all experts, this is how we are not able to give a guaranteed result, and it becomes like a abail mujhe maar. So revision surgery, plate removed, debridement of wound, expects for a period of 2 months, Klebsiella pneumonia grown, repeated sinus formation. So infection in orthopedic surgery is a disaster for both patient and surgeon. Increased antibiotic use, prolonged hospital stay, repeated debridement, prolonged rehabilitation, morbidity, mortality in higher rate of financial distress. Revision surgery after wound healing, signs of consolidation, X-fix was removed and functional brace was given. Journey of 2 years, fracture united with reasonably good function, exhausted patient and surgeon, and after 2 years still the patient, there are discharging sinus bothering me and to the patient. Sequestrum formation, patient wants to get it removed, a total FCM is pukkat, everything, because he is so much suffered with this type of injury. Therefore, one must think whenever there is infective potential and if you want to take a revision surgery, please God's sake, you have to explain to the patient that I cannot guarantee the result. So thank you very much. Thank you, because all speakers, they have talked very well about this, but they have not talked about the infection. And in literature, it is said by bicondylar plating and 3 approaches, there are 22% wound complication, which are to be kept in mind by all viewers. Thank you very much.
Thank you, Gadegone sir, for enlightening us on the dangers of complex fracture management, and we'll keep this always in mind. And on that note, I think this webinar will come to an end. We will invite Dr. Ashok or Dr. Neeraj to thank them. I think this was wonderful. It was really global 360-degree from anterior to anteromedial, posteromedial, posterolateral, Frosch, and the modified approaches. Thank you so much. Any summing up comment, Pranav, you would like to make?
Yeah, I would like to thank everybody. It was a great session, and I think the message delivered over here is not having individual approach for individual fragments. It is, I think none of the cases shared here showed more than 2 approaches at any point of time. So let us all keep this in mind, that we are not after posterolateral approach and anterolateral approach and medial, anteromedial and posteromedial 4 approaches or 360-degree approaches. The purpose of, I mean, it's not actually a fragment specific fixation. It's more utilizing the approach to get maximum number of fragments in one approach.
Right. Absolutely well said. That is what, so it is a decision making process. We are discussing the approach to learn from those approaches and to judiciously use those approaches. Jignesh bhai, you would like to sum up your comments?
As far as possible, one should avoid one more approach. I will try to fix up with single approach as far as possible. If need be, then you have to do a second approach. There is no choice, because sometimes the fracture dictates the approach. Some fracture has to be done by that approach only. You cannot do by other approach. So in that case, you have to follow the approach, but you have to follow the norms of soft tissue preservation and taking care of all the dangers which can affect your outcome. So most important part is that you as far as possible, select a single approach which can fix up the things.
Right. Dr. Sarvaiya sir, you would like to say something?
Just I would like to say that the soft tissue management is very important. So with experience, you just have a feel of the soft tissue, that how the soft tissue is going to behave. So you should have a ST pin or an external fixator ready in your emergency OT. So even in your OPD, if the patient comes and you feel that you won't be able to take the patient within 4 to 6 hours, you better put a lower tibial ST pin and give traction. Once you give traction and distract the fracture, probably the soft tissue will start healing. And if possible, if you want to send the patient home for 10 days, you put an external fixator. It is very easy. Put an anterior frame, give some 10 degree of flexion, and let the patient go home. Once the wrinkles are there, you have a decision power to which approach to take, and then the things will be very easy. So don't rush into it, but give some time to the soft tissues to heal.
Thank you very much. Kashyap, you would like to sum up in one sentence?
Yeah, everything is said. At the end of, say, one symposium, somebody asked them, confusing us. This is not regarding confusing. This is regarding letting them know all the approaches. But that's not that you have to approach. You should be open to your management protocol. The reading of CT scan is very important to decide that.
Yeah, thank you very much. I think that was really absorbing seminar and webinar. We learned quite a lot of things, and it would definitely help many of those who are listening to this webinar to plan their cases better, to use judicious approach, and to fix this patient to get ultimate patient benefit and a better patient function. That is what we always would be happy. Nothing like a pleasure where a patient comes and thanks us, "Saab, mera sab kuch theek ho gaya." And that is what we are all here to learn this approach. Thank you, faculty members. It was really great to have all of you on this webinar. Thank you, Neeraj. You are back in time, and thank you so much. We must really appreciate all your efforts to give us this platform to discuss all this complex fracture in the facility of our home. Thank you so much. Thank you, Ashok. And we could see now your background has changed.
Before we conclude, on behalf of all the faculty, let me thank and congratulate Dr. Chandak, because he has single-handedly navigated us through all the complexities. Somebody's video working, somebody's internet working, not working, all that. But he has made the entire transition very smooth. So, Dr. Chandak sir, great job done from
Thank you so much. Thank you. Thank you so much. It was really a wonderful learning experience.
I second that because I caused a lot of problem. My video and audio is not working, but thank you so much, sir, for the stream.
Not at all. In everyday theater in our OPD, we keep on solving problems. So that is, so every day, thank you so much. And we must thank Tanna sir, in spite of all busy schedules and everything, he could join and show us a nice case. So we would thank Tanna sir greatly. Thank you, Ashok. And I hope we'll continue with this series of
absolutely
360-degree approach.
We have to continue, even if you don't want, we have to continue.
We have to cover all the joints and all the approaches.
We'll definitely continue, and it would be interesting to continue with this series also. Yes.
Go with the pylon.
Yeah. Yes. Yeah, that is where we again it is global 360 degrees. And as we mature in our orthopedic tenure, we keep on learning one more approach which solves one more difficult problem. So
I must thank Jignesh bhai to promote me to use his approach.
Posterolateral approach. And not my approach. I just did it. Nothing my invention, sir. No invention. I am just executing the thing which I learned from the literature.
Yeah. And special thanks from me to Jignesh bhai, because I was to take on a posterolateral. Because of bandwidth, I requested. Suddenly took that. Thank you.
Kashyap, last time also there was a request from few delegates that if you can send us the recorded maybe we can adapt
I'll do it tonight, and
we'll just attach it to the webinar. Yes. I think whatever means Neeraj, his talk could not be listened. So if he can attach some way, I think that can be attached to the whole webinar.
In fact, I'll request all the faculty to send their surgical videos to us, because many a times through Zoom streaming, the quality decreases. Right. So we'll incorporate those videos and put them in.
That would be a great idea. Thank you so much.
Thank you, sir. Good night.
Good night.